You may be thinking, am I in the right place? This doesn't feel like a surgical training center. Because it's more than that. It's an education epicenter where meeting spaces hold landmark gatherings and surgical instructors can impart and inspire. This is where technology and hospitality move in unison. A full-service medical meeting resource connected to an award-winning hospital, where life-saving surgery can be studied in the OR and practiced in the lab, and life-changing technologies find their proving ground for success. Because the world of surgery is diverse and ever-changing, we give you a place and a team that can adapt to and accommodate any training, meeting, specialty lab, or equipment need, beginning to end, thinking of every detail in between. It's where one-of-a-kind resources meet five-star service to create dynamic, seamless, unforgettable events. So if you're looking for something more in your surgical training center, well, you've found the right place. It's the Nicholson Center, and it's unlike anything else.
Introducing the airlift procedure for obstructive sleep apnea. Siesta Medical has developed the ideal system of implants and instruments for performing hyoid suspension. The procedure begins with a small incision under the chin. Two very small suture anchors are placed under and behind the chin. A second small incision is made directly over the hyoid bone, and the hyoid bone is located and secured. The Revolution suture passer, which simplifies passing sutures, is used to place two loops of suture around the hyoid bone. These are then attached with girth hitches and passed through to the first incision. The sutures are then threaded into the suture anchors using preloaded threaders. With the head in a neutral position, the hyoid bone is advanced and suspended to the mandible with the suture anchors. With the Encore's suture anchors, the position of the hyoid bone can be easily controlled and adjusted at a later date. The airlift procedure is completely reversible and removable.
Hello, everyone. Good morning, good afternoon, good evening. Wherever you may be in this world, I hope you're safe and healthy. I'm Scott Magnuson. I want to welcome you to our 8th annual Obstructive Sleep Apnea Surgical Dissection course. Unfortunately, this year we have a virtual meeting. One benefit of this virtual meeting is we have over 900 registrations for this meeting, the largest meeting that we've had to date so far. We represent 68 countries for this meeting, and I want to congratulate all of our faculty from all over the world to help promote this course. I'm in the Nicholson Center in Orlando, Florida. Many of you have been here before, and I'm sorry we couldn't be together again today. I look forward to next year, where we already have our dates set for the end of February 2022. Registration is open, so if you would like, please register for next year's course. It will be in person, and the highlight of this meeting is the dissection component of the course. I don't want to take too much of our time this morning. I want to introduce our co-directors, Filippo Montevecchi from Italy, Julia Crawford from Sydney, Australia, and Claudio Vicini from Italy. Claudio, I think you have a few words to say.
Yeah, thank you. Good day to everybody everywhere, irrespective to the time. I'm very happy to be with you today. I miss the place, I miss Nicholson, but I'm sure that we will have another chance next year. What we decided to do this year is to work anyway, to share anyway, irrespective to the pandemic. So we are together today, and we will share our expertise in surgery with an incredible faculty that you will learn to know in the next day. Nothing more. Welcome and enjoy the course.
Thank you, Claudio. I want to thank our sponsors this year. I especially want to thank our gold sponsor, Airlift, from Sleep Source Alliance ENT, but also to congratulate and thank our silver sponsors, Inspire, Stryker, Philips, Olympus, Nyxoah, and the Florida Society of Otolaryngology Head and Neck Surgery. Without this, it would be very difficult to hold this meeting, even in a virtual setting. Thank you very much for your support. We'll begin our first panel this morning. We're going to start with a nose. And my good friend Julia Crawford from Sydney, Australia is the moderator for this panel. I'll let her introduce her panelists. And Julia, it's yours.
Hello, it's really lovely to see everyone. So firstly, we're going to be having two parts to the session today. The first one will be presenting on the medical assessment of the nose, and the second part will be going through the operative steps for treatment of the nose in the setting of sleep apnea. So I'd very much like to present our first speaker. Dr. Tong Sa To is a senior consultant in the Department of Otolaryngology and Sleep Disorders Unit in Singapore General Hospital, and also that is the head of Sing Health Duke NSU Sleep Centre. Along with his clinical work, he contributes his time as an executive of the Singapore Sleep Society and as a principal investigator of the Sing Health Foundation grant to explore innovative surgical techniques for the treatment of sleep apnea. He'll be talking to us today about the nasal evaluation and medical treatment of the nose.
Hi, good morning, everyone. Today we are going to talk about nasal evaluation in a patient with obstructive sleep apnea and discuss some of the effects of medical and surgical treatment. I have no conflict of interest to declare. So today we are going to discuss why the nose is important and what we need to ask in the history, the physical examination, and what we need to do for the patient by gleaning some of the evidence from the literature. At the end of this talk, you'll be able to know that the nose is related to sleep. What are the questions you need to assess in a patient with nasal obstruction and sleep apnea? What are the clinical examination you need to do? And what are indications for surgery in this group of patients? So for patients presenting with symptoms of OSA, it is important for us to ask about symptoms of allergic rhinitis. And if they don't have, it is important to ask about nasal obstruction as well. And not just about nasal obstruction during the consult. It's not sufficient to just say, is your nose blocked? It is important for us to ask whether or not during the night time they have nasal obstruction, whether or not when they lie down, do they feel that their nose is blocked? In the middle of the night when they sleep and they wake up, do they feel that their nose is blocked? And the day when they exercise, whether or not their nose is blocked as well. So why is it so important to ask about nasal obstruction? way back in 1717, we already know that nasal polyps is associated with restless sleep. And we know that neonates are obligate the nasal breather, and during upper respiratory tract infection, it is difficult for many people to go to sleep or to sleep soundly because their nose is blocked. So even in the ARIA guideline for classification of severity of sleep apnea, the presence of abnormal sleep already put the patient in a category of moderate to severe allergic rhinitis. What epidemiological studies tells us is that nasal obstruction allergic rhinitis puts the patient at higher risk of sleep-disordered breathing. And isolated nasal nocturnal obstruction alone put the patient at high risk of habitual snoring, of daytime sleepiness, as well as non-restorative sleep. And because nasal symptom is so common in patients with sleep-disordered breathing, it is incumbent on us to ask about that in the routine history taking. And we know that 60% of the total airway resistance is contributed by the nose. It is important to ask for nasal obstruction in the supine position because studies have shown that in the supine position, patients tend to feel their nose is more blocked, even though in the upright position, they say that their nose is not. And studies have shown us that in the supine position, the nasal resistance is higher. And studies have also shown that while REM sleep is associated with increased nasal resistance, and that may be the reason why some patients, when they wake up in the middle of the night, they feel that their nose is blocked, or during REM sleep, the events of obstruction is higher because they have to open their mouth to breathe. So knowing some of the history that we have to take, now we're going to explore the mechanism that are important in stabilizing the airway and why the nose play such an important part. So we are all familiar with how the upper airway is modeled as a Starling resistor, and how the collapsing pressure and the dilating pressure contributes to the P crit when the airway air flows through the airway. And what is more important recently is that instead of it being a fixed model, people are talking about it being a variable model whereby the upstream pressure, midstream pressure, and the downstream pressure, and this inspiratory effort contributes to the airway obstruction. So if you imagine that the nose is blocked and the patient is trying hard to try to breathe in through the nose, what naturally they will do is that you make the tube more collapsible, like how we suck into a straw that is narrowed. And they also try to open their mouth to breathe, which is detrimental. How is that detrimental? So as you open your mouth to breathe, the mandible move posteriorly, the pharyngeal airway size decrease, there's increased compliance of the tissue of the airway, and of course increase airway resistance. Next thing is that, of course, when you breathe in through your nose, it actually helps with minute ventilation. And studies have shown that, the minute ventilation compared to oral breathing is much better. And some of the studies actually shown that there's improved pulmonary function after nasal surgery, even in patients without obstructive sleep apnea. The other reason why nasal breathing is important is because of the nitrous oxide that's produced by the paranasal sinus. And that has a role in maintaining the upper airway patency, as well as regulating sleep and neuromuscular pathway to stabilize the airway. Now that I've gone through the points that we've taken in the history and understand the mechanism why nasal breathing is important, we're going to go through the physical examination. As per all ENT, when we look at the nose, we look at the inferior turbinate, we look at the nasal septum. And what's important to note is that even if the patient do not complain of any nasal obstruction, it is important for us to observe the nasal mucosa to see whether there's any signs of allergy and whether or not the patient may not be able to feel the nasal obstruction, but it actually contributes to increase nasal resistance. And if that happens, you still have to treat the patient even though the patient is asymptomatic. In addition to looking at the levator nasal septum, as well as the inferior turbinate hypertrophy, It's also important for us to assess the septal swell body. And recently, the computational fluid dynamics have shown that when the airflow predominantly towards the middle meatal region, and the septal swell body is just anterior to that and may cause obstruction to airflow. During the nasal endoscopic examination, we would have also examined for presence of nasal polyposis as well as adenoid hypertrophy. And after completing the nasal endoscopic examination, it is important to look for any dynamic collapse of the nose that can contribute to the nasal obstruction. And in this case, you can see that the internal nasal valve of this patient, especially on the right side, is at fault, causing a nasal obstruction, especially when the patient take a deep breath in through the nose. So in this patient, you can see both the internal nasal valve coming in when the patient breathes in. Well, normally it is supposed to dilate to allow more air to go through because of the action of the dilator nasi. So if you use Cottle's and modified Cottle's maneuver to see whether or not the patient internal nasal valve stabilize, you can get an idea whether or not nasal valve surgery will help the patient. So broadly speaking, nasal surgeries can be done for static obstruction as well as dynamic obstruction. And at CNT, I think most of us are quite familiar with the surgery and the different techniques that we can do. And later, Ofer is going to show us some of those techniques. Okay, so this is just one picture video of a patient who has internal nasal valve stabilization, and you can see that, well, the internal nasal valve doesn't collapse anymore. There are three effects of nasal treatment. Number one, of course, we reduce the subjective sensation of nasal obstruction, improving their quality of life, not just during sleep, but in the day. There's a possibility of reducing sleep-disordered breathing, possibly even eliminating it. And of course, we want to facilitate CPAP usage. We know that nasal treatment, either medical or surgical, can eliminate about 10 to 15% of patients with sleep disordered breathing. We also know that the nasal treatment can potentially improve sleep architecture, improve sleepiness, improve quality of life, although the AHI may not change significantly. And if you were to choose a patient whereby you're going to operate or treat medically, to improve their sleep disordered breathing, it will be those patients with mild sleep apnea, with normal cephalometric imaging, normal weight, and normal oropharyngeal findings. I also mentioned that normal nasal breathing is important to help the patient be compliant and be adherent to CPAP and to initiate CPAP. And studies have shown that if a patient has got nasal obstruction or increased nasal resistance, they are less likely to be able to use CPAP. And treatment, either medically or surgically, can help improve that statistics. And the interface, I'd like to emphasize that for mouth breather, it's not a full face mask. I think it's important for us to examine the nose carefully and address all those areas of obstruction, because the best, I would say, best treatment or interface for patient with obstructive sleep apnea is still the nasal interface. Depending on the history and what you find on physical examination, these are some of the medication that you can use for medical treatment of allergic rhinitis, of this nasal polyposis that will help before surgical treatment is considered. And one of the interesting studies have shown that, well, it's not just whatever is happening in the nose that can cause a sensation of nasal obstruction. Even tonsillar enlargement can lead to a sensation of this nasal obstruction. And, it is not surprising because, if the retropalatal area is narrowed because of enlarged tonsils, that can potentially block out the passage whereby the air can flow through the nose. So it's important, to look into oropharynx to make sure that there's no tonsil enlargement even while you're just assessing the nose. So in conclusion, clear nasal breathing is important in patients with sleep disordered breathing. And I hope that the presentation will help you understand why that is so and how it helps you in your clinical practice, in your history taking, in the physical examination of patients. And medical treatment and surgical patients are both available to help the patients. With that, I thank you.
Hello, I'm Ofer Jacobowitz from New York, New York, and we'll be discussing new and less invasive methods to treat the nasal valve. My disclosure is having been the primary investigator on Aaron Medical's nasal valve treatment FDA trial and subsequent consultant for them. This is what we wish we were. Great times with great friends in Florida and beyond. Hopefully next year. We're all very well aware that nasal obstruction is a major impediment towards successful treatment of obstructive sleep apnea using any means. Nasal obstruction has a major negative effect on CPAP adherence. And when we treat nasal obstruction, there's a reduction of CPAP pressures by about 2 centimeters, and both CPAP adherence and CPAP acceptance improves. Nasal surgery often only treats the AHI successfully in about a fifth of the patients, but nonetheless, it is critically important to treat. Even without sleep apnea, we know that nasal obstruction fragments sleep, and breathing through the nose during sleep as opposed to breathing through the mouth is much easier. The ratio is about 2.5 in terms of the work involved to breathe through the mouth during sleep as opposed to the nose. The nasal valve is often overlooked. If you don't have a good hammer, then you don't see the nails. And so if we don't have an easy way to treat the nasal valve, we often don't look for it clinically. As we all know, it's the major resistor of the upper airway. It's bounded by the septum. It's bounded by the head of the inferior turbinate, as well as the lateral nasal wall or the caudal border of the upper lateral cartilage. The diagnosis of nasal valve obstruction is actually a clinical diagnosis. The typical treatment of the nasal valve is often problematic. When we use over-the-counter treatments, such as external or internal dilators, they require continuous use, not always comfortable, not always used long-term. When we talk about traditional surgical treatment of the nasal valve, there are issues with cost, general anesthesia for the patient, risks, complications, and recovery. For this reason, less invasive means are sought by patients. So what are the patient factors and issues that can help us decide on the best course of action? Well, the simple patient is a symptomatic patient. What if the patient's asymptomatic? Technique I often use is to point out the obstruction and then have the patient return at a subsequent visit. They may become aware of the issue in the interim. Next question is the patient's preference. Some patients will not wish to undergo any procedure under local anesthesia, or there may be cost issues that determine where and how they wish to have the nasal obstruction treated. The degree of septal deviation is important. A patient that has a severe septal deviation perhaps may be a better candidate to undergo surgery in the operating room, especially if it's a caudal deviation. Although there are some techniques that I'll show where the septum can be treated in the clinic. And of course, the patient that has severe cartilage deficiency post-rhinoplasty, again, this may be a patient that may wish greater reconstruction of their nasal valve. So let's go over our menu of approaches. There are suspension fixation approaches, which can be done to the face. There's a suspension that can be done to the bony rim of the nose. And of course, there are direct modification approaches. These can include an intranasal Z-plasty by Dutton. These can be the alar splint by Stupak. And there are direct modifications using radiofrequency, and this is the Vivera device. Likewise, there's an overlay approach, which includes the Latera implant. So what are the suspension approaches? An old approach by Paniello was suspending the nasal valve to the orbital rim. This was modified by Friedman by using a suture that has an anchor connected to it. Again, orbital rim approach. And then Ed Weaver came up with a shorter trajectory for the suture by suspending the nasal valve using a suture to drill holes in the piriform aperture of the nose to the nasal bone. This is a technique we typically demonstrate during the course, but hopefully next year. Direct modification of the nasal valve can be performed using a simple Z-plasty. This is the technique by J. Dutton. Essentially, one draws a line along the intercartilaginous line and then performs a Z-plasty with two triangular flaps of mucosa. You lift the mucosa, resect a small amount of upper lateral cartilage here, and then rotate the flaps. And this results in a wider nasal valve. Again, this is a technique that we will demonstrate in the lab, hopefully next year again. Another way to directly modify the nasal valve is through radiofrequency and pressure. This was hard for me to understand at first, but then I looked at these papers where taking a piece of tracheal cartilage, one is able to bend it by heating it to 60 to 80 degrees centigrade and applying pressure. And then there was actually a study by Sarin and colleagues where through an intranasal incision, radiofrequency energy was applied to the nasal valve, and this resulted in symptomatic relief of the patients for the nasal valve obstruction. So on the heels of the prior studies, Aaron Medical designed a stylus to deliver radiofrequency energy inside the nose without performing any incisions. I performed with many colleagues in multiple centers a clinical trial, selecting patients that had a positive caudal maneuver or responded to wearing nasal dilators of all sorts. And these were patients underwent a single treatment in a clinic under local anesthesia. The nose score declined from 80 to 25 at 6-month follow-up, and 25 means little to no obstruction of the nose. There were no major complications. The patient returned to work the next day. The results were durable in terms of the nose score at 24 months, and patients at 24 months likewise remained in the minimal to no symptom category. Procedure was very simple to perform, safe to perform. Issues could be one of cost because there is no CPT code in the US, although some people have used 30117, 30802. So how do you do it? Very simple. There's no incisions. You simply identify the nasal valve region. You apply topical 4% lidocaine or tetracaine for 15 minutes. The nose gets numb, and that allows you to treat also the inferior turbinate and the septum to some degree if you wish with a device. You inject the local anesthetic through using a 30-gauge needle and only a tiny amount into the nasal valve to raise a little bubble. The patient feels little to no pain from the injection, and then essentially just apply the radiofrequency energy using a stylus 30 seconds at a time, applying pressure, and the temperature is about 60 degrees centigrade. So how do we do it? This is a time-lapse video. Here we're putting in the local anesthetic into the nose, topically removing it, injecting the local anesthetic next into the nasal valve, just raising a little bubble, tiny amount with a very small needle. Once this is done, it's not fast enough. We apply the stylus with a conducting gel and essentially apply pressure and heat about 30 seconds at a time to each spot. You may wish to go back and then retreat a spot depending on how it appears to you. And you can use the same stylus to treat also the turbinates as well as certain areas in the septum possibly. This is just to show you how easy it is to do it, how the patient is comfortable, sitting in a regular chair, painless.
And you tell me if you're experiencing any trouble.
Lifting the nasal valve. Another technique to treat the nasal valve in a minimally invasive fashion is using the Latera implant, which essentially is a needle-deployed implant that sits over the nasal valve region, resting on the nasal bones. Trial was done by Pablo Solovitsky and colleagues in multiple centers, and they had two groups of patients. Patients that just underwent the implant insertion, and patients underwent implant insertion plus septum and turbinate treatments. This was an interesting population because almost 90% of the patients had prior rhinoplasty, and 50% of the implant alone patients had a septoplasty before, and I think close to 80% of the patients of the multiple procedure group had prior septoplasty as well. Essentially, the nose score was assessed, and what you can see here again is that the nose score initially was 80 in both groups, and with treatment, the nose score declined to 40 in the implant alone group and to 24 in the multiple procedure group. So, and again, this is a treatment very straightforward in terms of just placing an implant on the via a needle. So with the Latera implant, the concept is to support and lift the nasal valve region using this polymer that should absorb by about 18 months. It comes in two sizes, 20 and 24 millimeters. Like all implants, it carries the risk of a foreign body reaction that can be hypertrophic on occasion. Initially, there is some possible visibility, or at least when the patient actually moves the skin, they may be able to see it. And like all implants, there's a risk of migration, extrusion, and infection, of course. The procedure is quite simple to perform. This is an early case, so it was performed under general.
Again, with pre-mark.
There is a template that you can use to pre-mark the skin.
The insertion this way, this helps us see
the needle is about 16 gauge.
We want to stabilize the entry, so we're going to use a
the dots mark a line that's about midway between the dorsum of the nose and the cheek. You want to evert so you can pierce the skin, twist it in. Once you're in, you can just straighten the lateral wall. I can even do it with 2 fingers without the 2-prong, easier actually. As you pass, again, especially early on, you may find that you're a little too superficial. So you can back it up and get back into the best plane.
Here, the angle though is to rotate it back. And again, the line is about midway between the dorsum and the canthus.
You want to end up over the lower end of the nasal bones.
Nasal bone here, right there.
And you can actually move it in order to see where you are.
So make sure we're perpendicular.
So parallel to the lateral nasal wall.
Because we don't want to have
you want to deploy,
bounce back,
making sure the implant doesn't pop out.
Or deployed, hold it while
and then pulling the needle out while you're holding the implant in place. And that's it. Very simple to do. Of course, local anesthesia is harder because you have to anesthetize the rim of the nose. And last but not least, we can also treat the nasal septum in our clinic under local anesthesia or local anesthesia with some sedation. Again, the concept is that once you get good anesthesia locally and the patient is not very nervous, one can do a lot of work in the nose. And this can be a traditional septoplasty. Of course, you may not wish to do this on a very complex caudal septal deviation in the awake patient, but we do have the ability to do traditional type of septoplasty, or we can do a more limited that involves the use of tools such as the balloon to fracture or mobilize a septum, or we can use septal burrs that connect to a motorized handpiece that allows us to submucosally shave off spurs or certain regions of the septum that we want to thin. The Acclarent Relieva track balloon is a tool that can help us treat the septum. Again, the key is to use good local anesthesia. And for this, I typically take pledgets. I place them in the nose. They're soaked in topical tetracaine jelly for about 15 minutes. And then I inject local anesthetic. The patient very often will get a very, very low dose of oral sedation. And then essentially one deploys the balloon in the nose. The balloon will actually help move and fracture the septum off the crest. And that allows you to then easily dissect off typically spurs from the septum through an incision that is made in the septum. So here's a video showing a little bit of how it's done. So this is a septum that is severely deviated in this patient. Complete obstruction on the left-hand side. Of course, pledgets need to be placed in the nose, and we need to wait. This is just testing the balloon. It's going to be a super rigid balloon when it's inflated, and it cracks. So I warned the patient about that. I put it in the good patient side first. Pressure also gives us hemostasis, and this is what it looks like after deployment on the left-hand side. So remember, there was no airway on the side. Now the airway is actually very significantly patent. And at this point, one can make an incision in the septum here to dissect out this spur, and that's quite easy to do. In addition, since the tissues have been compressed, if you wish, you can at that point treat the turbinates with very little bleeding. And so in summary, treat the nasal valve. It can result in significant benefit to the patient's quality of life and treatment of obstructive sleep apnea. We have less invasive methods available that you can utilize either in the clinic or the OR, depending on your comfort level and availability. Always consider the anatomical factors of the patient with a severely deviated caudal septum, very complex septum, maybe better candidate to perform in the operating room. Consider the patient's factors, their comfort, and their acceptance of what you wish to do. And I thank you for your attention. I wish to thank you all for joining us and watching the presentation. Please stay tuned for the discussion. I really hope to see you in person sometime very soon. Thank you.
I just wanted to say thank you very much to both Ofer and Songtar for the very interesting presentations. We have some questions from the panelists. So I'm just going to, some questions from all of the people watching. So first of all, there was a question regarding the evidence for partial turbinoplasty and whether it's superior to more other techniques such as coblation or radiofrequency ablation to the turbinates at decreasing nasal resistance as part of multi-level surgery.
Right.
Yes.
Offer, like that, since you started.
I'm sorry, yes. I do think that it's advantageous to do physically to do a submucosal turbinoplasty where you can remove bone. That's where you can achieve greater volumetric reduction. But depends on, for example, when I use the Vivera tool, I use it to treat multiple sites in the nasal airway. So I will use it to treat the turbinates, I can use it to treat the nasal valve, and I can also use it to treat the nasal septal swell body. So it depends what tool you have at your disposal and what the most important pathology is in the nose, because the turbinates is one zone, but obviously there's multiple zones to treat. So it just depends on what the individual factors are. And sometimes when you look at the nose, that's exactly what we need to do. We got to assess what's the more critical zones that we need to treat in order to achieve the greatest patency. And of course, we're doing things a little bit primitively because we're increasing volume, but we don't know exactly how to increase flow. And that's something we need to figure out.
There was a question from Dr. Hoff to Dr. To about whether you can, is there any techniques that you use for alleviating rhinosinusitis in CPAP patients? Because it was saying that you obviously tend to get a bit worsening of symptoms when you're using CPAP.
Yeah, so unfortunately, I think there is no method to prevent rhinosinusitis from occurring in a patient using CPAP. But I think if a patient has rhinosinusitis, of course, you need to treat it either with medication and if not, surgical treatment. And I think it's important for us to warn patients that, their nasal symptoms may get worse or they may develop rhinosinusitis with CPAP use, and to come back and see us for assessment and treatment if that occurs. So I think the counseling part is while preempting, that is important so that patient will know what to look out for. And if not, if the nose gets blocked, they start having mucopus, mucus, that may prevent a good CPAP compliance. Over.
Then there was a question from Dr. Seuss regarding the algorithm that you use, OFA, for techniques in the nose. Do you start typically with a septoturbs and then move on to nasal valve surgery like Vivere as salvage?
Great question. It depends what's available and what the key pathology is for the patient. So if the patient has predominantly obstruction secondary to the septum, that would be the first thing I would treat. And certainly if the patient, depending on the degree of septal deviation, I'll do it obviously either in the OR or in the office. But it really, the anatomy dictates, and then what's available at your hands and the patient's preference. No straight answer.
So one of the further questions was whether there's any study comparing the new approaches that you demonstrated over more traditional rhinoseptoplasty techniques.
So there's no head-to-head comparison study. What's basically used in all these studies is the nose score, and the nose questionnaire scores are very comparable between the results of major reconstructive nasal valve or rhinoplasty with both of these minimally invasive approaches to the nasal valve. So at least the patient reported outcomes appear to be the same in terms of the magnitude of response.
Julia, I want to thank you for putting together an excellent panel on the nose. Song Tarto, Ofer, thank you for your participation and your presentations and the time. Anyone can look at the chat box, including panelists, and you can answer those questions by typing an answer. We're going to move on to the next panel, however. So thank you very much, group, for this. I do want to mention, again, there are many questions about recordings. This will be available on the Nicholson Center website beginning on Monday. So the entire presentation today and tomorrow will be available on the Nicholson Center website, and you can watch it. Just follow the link that is emailed to you from the Nicholson Center. Also, we have over 250 participants right now in this meeting. I want to congratulate everyone for joining in. I look forward to seeing that number grow. For those who are interested in coming to Orlando next year, February of 2022, this is really focused on hands-on dissection. This course, the benefit of this course is the hands-on dissection along with the faculty. We have a cadaver lab here at the Nicholson Center where in the mornings we have these lectures, in the afternoons we do the dissections. If you're interested, there are 30 spots available for dissection. You can go to the Nicholson Center website to register for next year's meeting. We're going to move on to the next panel. I want to welcome Stuart Mackay from Wollongong, Australia, just south of Sydney. He's put together a panel, and I'll let him introduce this panel. The focus will be on palate. So the next 90 minutes, we're going to focus on surgery of the palate. Stu?
Great, thanks, Scott. How's my audio coming through okay?
You sound great.
Good, terrific.
You don't look good, but you sound good.
No, I'm somewhere between me and Ed Weaver at the moment. So, look, welcome to the palate section of Florida OSAS 2021 style. And whilst we're evolving in the virtual world, I remain uncertain exactly how this might play out. So just be patient with us, and hopefully we'll learn. And for those that are joining from around the world at the wee hours of the morning or late at night, and you're struggling to remain attentive, remember your resuscitation, your CPR, coffee, Pepsi, Red Bull. So let's start the first slide if we can. So we'll click on. So my fellow panelists today should really need little introduction because they sit high atop the sleep surgery chain of knowledge and wisdom, with world leadership status in Egypt, the renowned Yassin Bhagat, and in Italy, the great Claudio Vicini, and of course in the US, the legendary Tucker Woodson, and then unfortunately me. Slide. So the way we'll try things is we'll do case-based lead into particular operations that Professor Vicini, Bhagat, Woodson and myself can describe, but please note that in most instances, we'll make the assumption that a full and detailed clinical assessment, dynamic airway evaluation, polysomnography and device use trials have already been undertaken, and we'll therefore probably skimp a little bit on some of those details in the process so that we can get to the key principles of surgical application and technique description. Slide, please. So let's start with the first case, which is a 33-year-old male who snores, can be heard downstairs when he sleeps upstairs. There's been some witness pauses and gasps in his breathing. He's unrefreshed in the morning, sleepy during the day, and starting to suffer some sleep intrusions at work where he naps in the afternoon at his desk. Slide. And if we could click the next two, yep. So this is his Epworth sleepiness scale, which is elevated at 15 out on 24, and he's snoring every night for most of the night and can be heard downstairs or down the hallway with a snoring severity scale of 8. Slide. And here's his sleep study, which overall shows just moderate obstructive sleep apnea, just into the moderate range, but mostly hypopnea, no major desaturations, and so described as mild to moderate or just borderline moderate. Slide. So we might start with Claudio. Claudio, this chap has, let's say he has mid-range, sort of moderate size 2+ tonsil. He has some tonsil and lateral pharyngeal wall generated collapse on your dynamic assessment. He's got a sort of mid-range to smallish tongue that sits below the occlusal plane. He's got a normal nose and nasal mucosa, and his body mass index a little bit elevated, normal craniofacial structure. And just click again, please. And we'll presume he's failed CPAP. Claudio, this chap comes to see you with this sort of anatomy and this sort of a story, and he says, look, I've read all about your procedure. Do you think that BRP would be suitable for me? Slide. And we'll cut over to Claudio if he's there still.
He's already commented.
Got him. Can you, yeah.
He's already commented. I can't see any more of the picture.
can we bring back the slides?
May I go slide, please? Okay, again. Now we are indicating the landmark that we need to recognize in order to perform our surgery. Of course, the uvula, the posterior pillar, right there. Very important, the pterygomandibular raphe, that is a key point for performing BRP. The soft palate along the midline, you have to find the posterior nasal spine. That is another key point. Here we are completed the tonsillectomy, and what we are doing now is to remove a minimal amount of mucosa at the top of the tonsil fossa. Working in this way, we remove a minimal amount of mucosa, but much over, we remove fat, salivary glands, a minimal amount of muscle. That's a good way for let that the posterior pillar, the palatopharyngeal muscle that we are now approaching, is easy to replace in a new position anteriorly, laterally, and superiorly. With the left hand, we grasp and we pull the palatopharyngeal muscle, and step by step, we release the posterior pillar, the palatopharyngeal muscle, in order to achieve a minimal amount of tension that will be easy to locate in a new position at the end. Now we completed the markings of the surface. You see on both sides the raphes, the posterior nasal spine, and what we call the intermediate point. Now we are inserting the needle from the midline. Is a bidirectional barbed suture device. Now we are passing to inside the muscle to the intermediate point, and then again lateral to raphe. This step is very easy. The philosophy of the technique is to keep all the time the suture inside the muscle, inside the mucosa. We don't have any single leg of the suture outside. That's better for the post-op. Now we are getting again to the same hole, and we are moving the needle to the tonsil fossa after tonsillectomy. Now we are biting the palatopharyngeal muscle. You see that we are biting a huge amount of tissue, really huge amount of tissue, as much as possible, from lateral to medial. We get out at the limit between muscle and mucosa of the pharynx. It's the first loop around the muscle, and again a second loop in order to stabilize it. After that, we get back to the raphe, lateral to the raphe, and we have just to pull. Nothing more than to pull. As you see, the new position remain correctly in the right place without closing a single knot. Why? Because we are working with the barbed suture system, which allow you to work to stabilize the tissue in the new position without any single knots outside the mucosa. After the first loop on the right, we move to the left side, and we repeat exactly the same. And what's another key is to try to balance the force in the right and in the left side. Is a key point. Working, moving any step right to left and left to right, you can assure that the tension of both sides is almost the same, and you don't overtense one side compared to the other one. Now you have a sample what happens immediately after the first loop, after and before the surgery. It's very quick, isn't safe, and it proved in many studies to be really efficient. That's all. Thank you, Stuart.
Claudio, whilst you're still on unmute, we'll pick up a question from Madeline Raufschlut, who's saying that sometimes doing barbed reposition pharyngoplasty, she gets a bit of tension on the posterior pharyngeal wall. Have you got any suggestions for releasing some of that excessive tension on the posterior pharyngeal wall during this procedure?
It's one of the best points. You know that it happens in the same way for UP3. It may happen in the past when we use conventional UP3. Point number one, don't overtense the suture. If you overtense, it's very difficult to go back. So be very cautious when you pull the suture. But in case you have just to push push the posterior wall and to release in a very slow way, in a very cautious way, and it may work. I never had a single case in which the tension and the web of the posterior wall became a narrowing of the pharynx. So prevention and treatment, just pushing down the crease.
And there's another question from Ahmed that suggests that sometimes occasionally some of these cases, you get a little bit of dehiscence and you get recurrent lateral pharyngeal wall collapse. Have you experienced that? And would you go back and revise the technique if you got that, or alter your technique in any way?
Absolutely, yes, especially for the first cases in which we did not so many rounds, not so many stitches between the posterior pillar, palatopharyngeal mason, and raphe. Now, following the suggestion of Marina Carrasco, which states that we need more turns for stabilizing, we used to do many more, and now it seems much more stable. Anyway, if you have a recurrence, you are able to address with an additional surgery, what we call iterative surgery, not pre-planned, but we have to explain to the patient that it may happen. Same for all the other palate techniques. And I think that it works really well.
Can we move on to the next slide, please? Next slide. Claudio, did you want to make any comments before you finish on your forthcoming text on this technique?
Yeah, I would like to introduce to all of you this book. We are working hardly in this book with the friends from Milan of my group. We try to put together the experience all over in the world, not only in Italy. And the book is dedicated to the memory of Mario Mantovani, a good friend who died a few months ago. He was the first to introduce barbed technology into sleep surgery. And so our aim is to collect all the main contribution in this new book. So that's all.
Great. If we've got Professor Bugger there, Yasin, can you unmute your microphone?
Yeah.
Yasin,
can you hear me?
Let's say this same patient is now decided that he's read up about lateral muscular wall and tonsil collapse, and he's prepared to travel the 4,000 kilometres across the Mediterranean to visit you, and he says, would you consider expansion sphincteroplasty on me for this anatomy? Can you describe that technique for us and how you go about it?
Okay, happy to see you, all of you, Claudio, Tucker, Woodson, Stewart. We hope that in the next year we'll be together. I am Yasin Bagat from Egypt. Next slide. This is Egypt. All of you know Egypt, well known by the pyramids, by the ancient Egyptian. And this is my city, Alexandria city, all over the Mediterranean Sea, beautiful city. Next. Yeah, expansion sphincter-pharyngoplasty was described by Kenny Bang and Tucker Woodson in 2007. The principle of this operation is to isolate the palatopharyngeal muscle, which is the main muscle in the lateral pharyngeal wall, and use this muscle and rotate it superiorlaterally and anteriorly to create tension on the lateral pharyngeal wall. And at the same time, you are removing the muscle. So you are removing the bulk of the lateral pharyngeal wall. Next. The technique consists mainly of tonsillectomy if it is not already done. If it is done, you can remove a small strip of mucosa in the bed of the tonsil to approach to the palatopharyngeal muscle in the posterior pharyngeal wall. Then we have to create a flap from the palatopharyngeal muscle and rotate this flap superolaterally in this direction. Once you do that, you can have a tension on the lateral pharyngeal wall, and you are moving the palate more anteriorly to relieve retropalatal obstruction. If the uvula is long enough, you can trim the uvula, and finally you approximate the anterior and posterior pillars together. Next. The technique, the classical technique, consists of tonsillectomy. We are now in the era of very conservative, very reconstructive, not destructive as before. So you do good tonsillectomy, you preserve all the mucosa muscle, and then in the posterior pillar you have this palatopharyngeal muscle. You cut the muscle and make a flap, and rotate this flap superolaterally and attach it to the palatal muscle here, and you can trim the uvula and finally close the anterior and posterior pillar together. This is a final picture after complete the procedure. Next. Next. This technique has been modified by many. One of the technique, now we are, for me, I learned this technique from Claudio Vicini and all his team in Forlì. They are using very nice procedure. Next. Next. The technique, this is a video. Yeah, we do in any surgery, sleep surgery, sleep endoscopy. This is retropalatal obstruction or retropalatal collapse by sleep endoscopy by tiles. In spite the patient has previous tonsillectomy, this is a patient. We create a flap from this palatopharyngeal muscle. We do medial incision here in the posterior pillar and the lateral incision. The medial incision, you should keep part of the muscle attached to the upper part of the posterior pillar and medially to have the traction required at the end of the procedure. Then the lateral incision, which is usually higher than the medial incision, you can use this monopolar cautery, Colorado tip, or you can use laser, whatever you have, radio frequency. And then you connect these two incisions to have this flap. The advantage of this operation is that you are removing this muscle, which is the main bulk in the lateral pharyngeal wall. So you are increasing the transverse dimension and expanding this pharynx. Then we connect these two incisions at the lower part. You can use curved forceps, tonsillar forceps. You connect this. This is a flap. You try to have a good bulk of muscle in this flap. And as a modification, we learned it from Claudio Vicini that to keep the muscle flap intact, we have suture here at the lower end of the flap. And this suture, we go around the muscle fibers to keep the muscle fibers intact. And this will help you again in the detachment of the muscle during the section. We keep suture here. At the end of the procedure, we cut these sutures. This is just to keep the muscle fibers intact during the section. All the time, try to don't go deep to the bed of the tonsil or to the inner surface of the superior constrictor. Otherwise, you may encounter great vessels in this area. And again, before cutting this muscle, there is vessel usually coming from the lingual vessels here. Try to cauterize this lower part of the muscle flap before detachment. Again, we turn around the muscle flap to keep it in a good fashion and to keep the muscle flap intact. Really, this technique is much difficult than the barbed techniques, but you can use it in any, if you don't have a barbed suture available, or if the bulk of the muscle is too big. This is very important. This is how to measure this. We are going to direct the muscle flap in this direction towards the pterygomandibular raphe and pterygoid humulus. Then we cut the muscle. Now we are cutting the muscle flap lower down. The length of this muscle flap should equal to this direction, otherwise it will be under tension and may detach. Now we are detaching the muscle flap. We are cauterizing the lower part of the flap by monobipolar cautery. This is a muscle flap. Try to keep this attachment, medial attachment intact, because we need this attachment to produce the required traction on the lateral pharyngeal wall and on the palate itself. The upper incision, as we are going to see, is more higher than the medial incision. Then we are creating, instead of cutting here or making an incision like classical technique, we are creating just a tunnel here. This tunnel can be done by curved artery forceps. You insert it towards the humulus and you open it. Now the tunnel is created. If you are going to do tonsillectomy first, the tunnel is already present at the end of tonsillectomy. Then, to keep the muscle flap inside this tunnel, we insert vicryl suture going from the pterygomandibular raphe or pterygoid humulus to the upper part of the tonsillar bed. And then we take the muscle flap. You can use one or two and then return it back. This suture, try to keep it half centimeter or maximum 1 centimeter away from the site of insertion here. This is the muscle flap. And you can take another suture for it, or second suture from here to the flap, to keep the muscle flap inside this tunnel and assure that traction is in good way. This is a first suture, and we are going to take another suture in this direction. One of the advantages of this technique is that you are going to stabilize this lateral pharyngeal wall, and at the same time you are moving the palate anteriorly and superiorly to relieve the retropalatal obstruction in this area. But it takes really more time than the barbed preposition pharyngoplasty. It needs more training than the barbed. Another secondary suture going from here to the muscle again, and then you return it back. And finally, you are tying these two sutures to keep the muscle flap inside this tunnel. Once you insert, of course, you have to do good hemostasis before closure of this wound. It only needs vicryl suture to 0. And then we return this second suture. Sorry for the video is playing in a very slowly way, but it is evident, it is clear. And then you return it back here. So once you put these two sutures together, you get the muscle flap inside the tunnel and have the traction required on the lateral pharyngeal wall. And all of us know that lateral pharyngeal wall collapse is very, very important in the pathogenesis of obstructive sleep apnea. And this lateral pharyngeal collapse was not dealt with by the classical uvulopalatopharyngoplasty before. You can, in a minute, you can see that once you tie this, you can get this all the muscle flap pulled and stuck in this tunnel. And the lateral pharyngeal wall is moving more laterally, and the palate is moving more anteriorly. Don't make over tension in this flap, otherwise it will be torn out. And once you do this, you will find that the flap, even the transverse dimension will be more than before of the pharynx. You are expanding the way in a 3 dimension, laterally, anteriorly, and in a more cephalic direction. This is once you do on one side, and then you repeat the same procedure on the same side. If the uvula is big enough, you can trim part of the uvula, but we don't advise amputation of the uvula to preserve articulation and to preserve good swallowing. You can compare before how the palate is moving more anteriorly, no retropalatal collapse at the end of the procedure. And you can close the pillars by 1 or 2 sutures. This is the final picture at the end of the procedure, how the palate, how the dimension markedly increased, how the retropalatal collapse and the lateral traction is maintained. And this is the main advantage of this operation, that you can relieve lateral pharyngeal wall collapse and at the same time increase the anteroposterior dimension of the palate. Next. This is before and after, how the lateral dimension increased and the palate is moving more anteriorly. Advantage of this operation, the more fibrosis in this area, the more traction will be evident, in contradiction to the uvulopalatopharyngoplasty. And uvulopalatopharyngoplasty, by time you may get some concentric collapse in this area. So you may get a stenosis after 1 or 2 years later on. But this will not happen in this operation. Next. Next. Yes, advantage of this operation over UPP. Yes. Next. Better outcome, as we described before, less invasive. Next. Minimal mucosal injury, it is more anatomically respecting. We are dealing with the muscle, yes. Muscle manipulation to splint lateral pharyngeal wall, yes. And as we said, that the vectors of an airway enlargement, mainly lateral, significant anterior and a minor cephalic vector. Next. Reduced pain. Next. These are a comparison between expansion and the classical UPP, reduced paresthesia. Next. And the risk of velopharyngeal incompetence is very, very low. Next. But all the time, respecting that we are dealing with the lateral pharyngeal wall, don't go more deep in the parapharyngeal space, because in 1% of cases we have the antenna carotid is just deep to the superior constrictor. So avoid deep dissection, try to be very conservative on the muscle itself. Next. And if you have some bleeding at the site of insertion of the needle, it's very easy to compress this point to stop the bleeding. If you have bleeding in this lower part, as we said, we usually use bipolar cautery. Try to spare medially sufficient amount of muscle attached to the mucosa of the posterior pillar to avoid mucosal injury, and at the same time, maximal posterior pillar sparing, as Claudio Piccini just mentioned. We have to preserve the posterior pillar maximally to avoid mucosal crease, stenosis, and to pull on the tongue. This will avoid many complications of this operation. I think this is the last slide. Thank you so much.
So we might, thanks for that, Yasin. And if anyone's got any questions, put them through on the texting. We might move on to the next case, which actually seems a little similar to the one before, but we end up with a bit more of a degree of obstructive sleep apnea. Yeah. So this is a younger male, 21, loud snorer, again, can be heard on a split level of the house. Unrefreshed in the morning, drags himself out of bed at 10 a.m, can get tired in his lectures, and has actually, interestingly, had previous rhinoseptoplasty before he was 18 years of age. So next slide. And this is this gentleman's anatomy. We're dealing with very large tonsil, size 3, low sitting tongue, almost to the point if you have an angled scope transorally, you can see the epiglottis. And let's presume we've got a significant amount of tonsillar generated collapse, as you might reasonably expect, even to the point of these lower poles of the tonsil compressing the epiglottis lower down in the airway. Next slide. And this gentleman, again, excessively sleepy, but has much more significant sleep apnea. An apnea hypopnea index of 78, repetitive desaturation to an nadir of 70%. His study was ended in the early hours of the morning, and he was organised for an urgent trial of positive airway pressure therapy. But he came to see me shortly afterwards to consider surgery. And I just want to use this type of a case, and I'll show you the completion anatomy at the end, as a springboard for describing the Australian modified U3P. So next slide. So to describe this anatomy, I just want to give you a broad overview of the technique and then a step-by-step sort of breakdown or analysis, and then we'll focus on some key tips and pearls. And I'll finish that component by directing those interested to the published literature. The last point there, the randomised controlled trial has been completed, and that incorporates this operation with radiofrequency to the tongue. So next slide. So basically the overview is the top the top left-hand corner, bilateral tonsillectomy, is followed by non-tooth forceps caudal uvular attraction to allow raising of a triangular mucosal flap of tissue. And underneath that flap, we excise an area of fat that's variably been described as supratonsillar fat or lateral platal space fat. And that creates a port into which we can subsequently divide. We can pass the divided upper 2/3 to 1/3 of posterior pillar mucosal muscle into that area or that space so created in a suture advanced technique. And the mucosa can then be closed over the top, and we can fashion a neo-uvula. So I want to go through that now in more detail, step by step. So slide. And if we can run the video. So this is just a bilateral mucosal preserving tonsillectomy in the setting of previous old school laser U3P, where the tonsils were left behind. And you can see just teasing the tonsil out, but maintaining as much pillar mucosa as we possibly can. Next slide. And we can run the video on this. The uvula gets pulled caudally to the contralateral, towards the contralateral foot, and we raise a triangular flap of mucosa that we can then subsequently elevate, with the upper limb angling up towards the maxillary tuberosity and the lower limb coming along the anterior pillar. So next slide. And we can run the video here. This is us just raising the triangular flap of mucosa so we can expose the supratonsillar or lateral platal space fat underneath, depending upon your preferred nomenclature. Next slide. And then play the video, and that fat we can then sort of, once it's exposed, we can tease it out, and we'll expose the underlying arching muscle fibers, predominantly of palatopharyngeus, a little bit of palatini muscle. Good, and next slide. Then we come to this complex of tissue, the posterior pillar, muscle and mucosa, and we can divide that a little more horizontally, and the tissue that's in the forceps is subsequently going to be suture advanced upwards. So we do that division approximately at the junction of the upper third and with the lower 2/3 of the posterior pillar. Next slide. This is the most critical step. We want a very big bite, solid bite with a suture that's used to advance that upper 1/3 complex up into the port that we've so created by removing the fat in the lateral platal space. And we're using a 3.0 Vicryl to achieve that. Next slide. And then play the video. And then if you wish, you can sort of close the mucosa over the top in a Z-plasty type configuration. And finally, next slide. We create a beveled neo-uvula to complete the operation. Okay, so next slide. And this is just about some words to the wise. What we really want to do, the only excised tissue in this operation is tonsil and submucosal fat, and a very small portion of the uvula, as the case may dictate. Importantly, there's no other palatal mucosa or muscle that's removed. And the technique, not dissimilar to what Yasin was saying, is all about repositioning, not ablating or deforming tissue. Next slide. As self-evident as it may seem, what you really want to do with this operation is leave the palate where you want it to be. If you're not happy with the position, you need to remove sutures, particularly the muscle-to-muscle apposition suture, or add extra sutures as may need to be the case. And you can use the nasotracheal tube as a guide. I know Tucker uses a mirror as a guide to see how much velopharyngeal port has been created. Next slide. Number 3 is it is reasonably appropriate to vary the division of the posterior pillar to accommodate different anatomy. For example, in this case, the tonsillectomy alone is going to achieve a significant impact, and you might only need a very, very small division to allow very simple superapposition because most of the treatment effects from the tonsil removal. Next slide. But this is the critical step, as I've mentioned. I'm just playing it again, and that's that really big bite and good mucosa, good muscle to muscle apposition, so that you get the palate exactly where you want it to be. And you've got to be content with it at the end of the operation because it's not going to get any better post-operatively. Next slide. And I have a low threshold for the addition of tongue treatment or multi-level treatment, even if it's just something as simple as radiofrequency to the posterior third of the tongue to achieve some minimal reduction or stiffening in that area, both to improve the snoring result and potentially to reduce subsequent globus. Next slide. And we can skip this slide. That's just describing the radiofrequency. Key is, I think Madeline asked this question on the chat about the BRP, but key is to try and not tent the posterior pharyngeal wall mucosa. You can see where the red arrow is highlighted here, there's some tenting of the mucosa. If there's tenting, you're likely to have some tension of other structures, and the worst one to have some tension on would be some traction on the tongue that pulls it into the space that you've so created. So be aware that you want to try and avoid any of those tension lines. It increases the chance the tongue might prolapse into the space. Next slide. I think what many of these procedures that we've talked about rely on are good sort of antero-supralateral velopharyngeal port opening. And exactly as you've heard from Claudio and Yasin, there's significant convergence of techniques to try and achieve this impact. And that's something that we've highlighted in several of these meetings in Florida over the years, and in several ISSS meetings, you know, from dating back to Detroit and Sao Paulo and LA. And so, Tucker, I'll just right at this point, I'll invite you to comment because you put this concept so eloquently now, just over 10 years ago. Can we go to the next slide? You still have the same feelings about what you said then?
Well, do you hear me there? Hopefully you hear me good. Yeah, I think that, you know, it's like rhinoplasty. You know, we're looking at functionally rearranging tissues, and, you know, in the past it was just a matter of resection, and here we really want to open up the airway, and there's different characteristics of the airway we want to address. I think that's important to recognize, and that's where some of the phenotypes come into. But do we want to, you know, reduce the length of the airway, address the lateral walls? You know, certainly in some patients, as you mentioned, the uvula is a big issue. In some patients, it's big tonsils. So it's really kind of coming up with a concept of which are the structural features that are really playing a role in the airway obstruction for the patient.
Yeah. I think Joachim had a question. Joachim, I like nasal intubation because it frees me up in the airway and I can do concomitant procedures to the tongue, but I don't find that it pushes the palate too far forward. In fact, the vast majority of the time in these cases, I find the palate is still very close to or even draped over the nasotracheal tube. And I use the resultant lifting off that we achieve with our sutures as a guide to how much improvement we've actually created. So we might go next slide, if we can. And so just to complete the loop, this gentleman had an excellent reduction in his Epworth Sleeping Scale, his improvement in his quality of life, actually complete resolution of his obstructive sleep apnea, much of which is from presumably the tonsil. And slide. Here's his post-operative appearance at 3 months down the track, slightly different colouring, lighting, but you can see small neo-uvula, well-opened supralateral velopharyngeal ports, a little bit of stiffening of the back third of the tongue, and all round a very good result. And just on the next two slides, I'll just you can flick through to the next slide. This is the original description of the technique if people want to read about it. So that'll be available to you. I think you can access. And the slide afterwards is the more recently published randomized controlled trial, a randomized clinical trial at which we tested this at a very high level in 102 patients randomized to this intervention or to best medical management and CPAP failure. So we'll just move on to the next slide. And sorry for the busyness of the slides that come here, but we're going to get a little bit tougher and a little bit more complex. So sorry, apologies for the small writing, but I'll try and read it out. If we could click to the next slide. And we can click all of these, yeah. So this is a 66-year-old chap. This is just derived straight from my letter that has long-standing known severe sleep apnea, 5 coronary stents inserted, concomitant cardiovascular risk factors, and he snores loudly, snoring severity scale 9, restless and disrupted sleeper, unrefreshed in the morning, tired and sleepy in the afternoon, elevated Epworth sleepiness scale. And in the past, when he was diagnosed with severe sleep apnea, he failed with a trial of CPAP after only a couple of days due to significant claustrophobia. He subsequently failed use of mandibular advancement splint due both to poor control of his disease with the splint and also poor tolerance of the device. Reasonable body mass index at 175 centimetres and 90 kilograms, but critically has fairly small tonsil tissue, an enlarged Friedman tongue grade, bulky posterior third of the tongue transorally and endoscopically, a retroposed flat palate with a vertical uvula, and at nasendoscopy, a limited O to V ratio, and very easy dynamic AP retropalatal collapse. With hard work, you can get a little bit of concentric collapse as well, but it's dominant AP. And jaw thrust improved the retrolingual airway, but actually made his retropalatal airway worse with the dynamic assessment. And with Woodson's hypotonic method, there was also significant AP retrolingual segment collapse. And essentially, we were already getting very close to a realm of failure before we started here because of his previous history. If we can click to the next slide. Those are his scales that we've already mentioned. If you can click to the next slide. This is a previous sleep study with mandibular advancement splint in, and you can see significant and profound desaturation in the top profile, top left side and across, and marked consistent obstructive apnea and hypopnea, even with the jaw split in. Next slide. I got him an updated sleep study with no device in situ, and you can see really, really severe oxygen desaturation and just one apnea into another, and hypopnea the entire night. Next slide. He actually had some old imaging performed for some other reason of his head and neck, and I got them to approximate the tongue volume based on that, which was confirmed that it was significantly enlarged. Next slide. And this was basically just we go to the back one slide. This was just my letter, the start of my letter back to his referring doctor about his very significant sleep apnea, that we were unlikely to have a repeat trial of anything. We're updating his cardiology assessment, and I actually booked him for what I believe is the best thing for his palate level operation and major tongue surgery in addition to that. But Tucker, from a palate perspective, if we're resigned to surgery in this chap and we've got no other options, what do you think we have here? And conceding that he's likely to have multi-level surgery, but we're addressing the palate in this particular panel, how would you proceed from here? And maybe you can run us through some of your concepts that you've discussed in the past regarding anatomy.
Well, yeah, we'll talk about anatomy. Get to the next slide.
Next slide, thanks.
Good. And the idea is here that we're really treating the airway, that think of it as more the conduit and the lumen and not just a matter of the soft tissues. And this is just a CT diagram kind of showing, a diagram of how we can phenotype the airway, and we'll get to in a couple of slides here. But you have to start thinking again, the conduit or the lumen, next slide, and not just the soft tissues around it. And so you have to have a way to kind of describe it. We've kind of used a simple way to do that, especially on the palate. And you get some idea of this when you look at this mid-sagittal picture. And you can see that there's kind of three segments anatomically, actually, of the soft palate. There's an aponeurotic segment, which is basically the tensor aponeurosis of the palate. And it goes from basically hamulus to hamulus. And actually, it's kind of the proximal third, or actually probably a little bit less of the palate. One of the landmarks that helps identify it is actually the fold of the anterior fold of the eustachian tube, or the tensor tendon. Actually, you can see endoscopically, or even on radiographs, you can see it go into the palate to help identify that. There's the middle muscular segment, which is mainly the levator muscle, but also laterally, certainly the palatal muscles play a big role. And then the lower or velar segment, if you look at it, when you combine these three, you end up with two segments of the palate. You have an upper palatal segment and a lower palatal segment. And the more proximal palatal segment has a different angle to it. We'll actually refer to that as the alpha angle, but we won't talk too much about it here. But you see in this case, it's the alpha angle is very, very parallel to the hard palate. In many patients, however, it's not this way. It's actually very vertical and actually runs very perpendicular to the hard palate, parallel to the posterior pharyngeal wall. But you can see that the distal segment actually is perpendicular. We call that the vertical segment. And we kind of assess then the different levels of the palate to the posterior pharyngeal wall. You can see the width of the palate at the hard palate, the area of the genu, which is the angle between, you see that proximal and distal segment. So there's an angle there, and we call that the genu, and you can assess that distance from the posterior pharyngeal wall, and then also the distance the posterior pharyngeal wall to the velum. And when you look at that, you can then get to the next slide. You come up with three different basic palatal shapes. You have an obliquely shaped palate that's open at the top, pretty much open in the middle at the genu level as well, and then more narrow at the velum. And we call that an obliquely shaped palate. And boy, that's pretty favorable for a lot of palatal techniques. So you can use, especially something like a barbed suture technique that Claudio's described, minimally invasive and can really pull the lateral walls out, which is frequently a problem in this group. I mean, this is a group really amenable to some of our less invasive sort of techniques, as is the intermediate to some degree. But here you're seeing narrowing at the genu as well as at the velum, but still relatively open at the level of the hard palate. And then you get to the patient here that Stu's described that has the vertically shaped palate that's narrow at the level of the hard palate, narrow at the genu and velum. And this is kind of the extreme example of just really the craniofacial growth problems that develop in sleep apnea patients, where they get this elongated airway. It's a much longer airway, but also retruded maxilla and just really a lot of compression. And so that's where our surgeries, actually, you mentioned earlier that the palatal surgeries, and we really get into this when we do the dissection courses in the future. We can go to the next slide. When you're actually in the lab and you can really go in there and dissect out the muscles and really see how these different muscles, we can go to either the next slide or the previous one, which shows the little lines there. And you can see that when this little vector diagram on the left, you can see each of these muscles really does contribute to the airway shape and size. And by repositioning either the bones or the muscles, you can really open up the airway and change its shape and size and different characteristics. But in the case that Stu's shown, really have this vertically shaped palate. And if you don't do something to address that, you're just not going to improve the airway in any meaningful way. Next slide. And this just shows that this organization, this phenotype, it's more than just an anterior posterior shape of the palate. It has quite significant effects also on the depth of the airway and also the lateral walls. They're all very much linked, such that the oblique palate tends to be a much more circular airway. It closes in a circular pattern. Whereas when you have this vertically shaped palate, it's just the opposite. You have this very flat pancake shaped airway, which is just horrible from an airflow point of view. These patients can be quite difficult to treat. They need something really to help pull the palate forward, either maxillary advancement or palatal advancement, but you really need to do something to improve that airway. Next slide. And this is just showing you the examples endoscopically, and you can see the three patterns. On the left, you see where the endoscope here is basically located at the level of the hard palate, obviously looking down at the larynx. And, you know, here we have a patient in the upper left, the top upper left, that, you know, you're looking at the hard palate and you can see the larynx, you can see the vocal folds. I mean, it's a wide open palate. And you can see that these massive palatine tonsils that are there. This patient's going to likely respond very well to just a simple tonsillectomy. The patient on the lower left, however, you can see these massive enlarged salpingopharyngeus, palatopharyngeus muscle group, although it's very open at the level of the hard palate. This palate really, the patient really needs an expansion, sphincterplasty, or probably something significant. Certainly even with the barb suture, if you're doing a barb suture technique, you probably need to reposition the muscle a little more proximally than you might otherwise. You look at the extreme examples on the opposite side, on the right side, right upper and left, you see no anterior posterior depth at all of these. Actually, just the opposite of the oblique, just almost no lateral muscle hypertrophy. It's just, this is just a straight, very narrow anterior posterior maxillary constriction type of airway. And then you have the intermediate, which is obviously a kind of a combination of the continuity of the both, where you can see significant narrowing of the genu of the palate. And frequently you can see that in the endoscope when the highlights change. You have the light of the scope, and when the proximal light is a different angle of the light, so you can see and define the genu frequently by that change in the light pattern. Next slide.
Tucker, you mentioned that you see this sort of vertical pattern a fair bit in, you know, maxillary constriction and craniofacial structural abnormalities. The other area that I seem to see it a lot in is previous palatine tonsillectomy, where the palate is scarred backwards, not forwards. It's compromised the airway. And it seems to be increasingly common that I'm applying this operation in that patient, and also concomitant lingual tonsil reduction because they've had some reason for lymphoid tissue to be hyperplastic once again in a different area when the palatine tonsil have been removed. Do you see that population as well?
I agree. And actually, it's interesting. You know, I've seen more, you know, when I see going and you do revision surgeries and you see these people that have very narrow anterior posterior airways and they've had prior tonsillectomies, that many of these patients do have quite significant scar back there. And I think it brings up the issue of tonsillectomy techniques that people use to avoid that type of scarring. And I know some of the folks in Brazil have done and advocated for much more conservative palatine tonsillectomy techniques to preserve mucosa and prevent that scarring down. But that obviously is, can be quite significant. And unfortunately, I don't know of a way until you actually get to the operating room to identify that. I find that, you know, I look in there, I don't know necessarily whether it's really a congenital or skeletal problem versus a scarring problem. And I don't know, does anybody have experience maybe even using radiologic methods? I mean, maybe this is a role for getting some, going back to using cephalometrics or skeletal measures to see if there's some prediction. I don't know. I'm open to thoughts on that.
Tucker, we might pick up one question from Offa there. He was just saying that in the patient with large tonsil and an apparently patent antero-posterior airway, he worries that the tonsils might be stenting that to some dimension. When you do tonsillectomy, do you do something to stabilize that area concurrently? Do you worry that the tonsillectomy sometimes can reduce the airway in some fashion?
Yeah, I mean, it's a good question, although I think that if there's, we know from clinical experience that in patients that have this good anterior posterior depth and you take out the large tonsils, they clinically seem to do well. That's just my experience. I do worry about that when you go into the operating room and you take out these big tonsils, and clearly in the operating room when the patient is under general anesthesia and their muscles are all paralyzed, you see this significant collapse of the palate. But I think functionally, when the patient wakes up and there's tone in those muscles, it probably functions differently than what we see in the operating room. That's my only explanation for it. But yeah, when I see people that I see that big collapse, I will frequently, you know, throw an extra stitch in the palatopharyngeus muscle and pull it up to the tensor tendon just to, you know, if anything, it makes me sleep better. I don't know if it helps the patient sleep any better.
Tucker, we might go back to our patient and run this video of his transpleural advancement. And as the video is running, I might invite you just to comment to the participants, different approaches, different incisions, etc., and give them some key points.
Yeah, we started this, always using this kind of Gothic arch incision, carrying it up on the palate fairly far. And this is especially with this Australian technique where a little more bone's taken and the flaps fairly thin anteriorly. You have to be real careful in elevating it up. Inject it well so you stop the bleeding. Be real judicious with any sort of cautery in here, and elevate it back pretty much just to or just barely beyond the bony cartilaginous junction. And then once you've actually done that, we're going to go in and just use I use a diamond burr to cut out the about 9 or 10 millimeters of bone here, and then free up the bone and the tissues laterally. And you really have to get in there and free up the tensor tendon and some of the muscles posteriorly, and ideally not violate the nasopharyngeal mucosa. Leave that intact, and that avoids having too big a wound post-operatively. And then you've freed up this bony island. I tend to make mine smaller. I know Stu and some folks make the bony island a little bit larger. And it may be that the bony island larger is actually better. It stays intact a little bit better. Sometimes the small one dehisces and comes off. But you can see there he's cutting that tendon and really freeing it up, because you really have to free up the tension on this, or else it just doesn't move, and then you end up with just too much tension posteriorly. And I think that's probably something that augments collapse. So actually by actually not freeing it up enough, you probably increase the risk of fistula formation. And so it's kind of somewhat counterintuitive that doing less results in more complications. I don't know, I'd be interested in getting Stu's thought on that as well. Then you have to do through and through palatal drill holes. This is actually using a little bit of a backbiting kerosene rongeur to take a few more millimeters of bone, but I kind of aim for somewhere between 8 and 10 millimeters of bone removal on most of my patients. Suction cautery or bipolar does a nice job. You get that nasal mucosa there, and then invariably there's a little bleeder at the end of the septum there, and that, like I say, responds well to that. They've done through and through drill holes. This is a little bit narrow. I'd actually like to leave a little bit more bone in this particular case for my drill holes. And then that sutures, which is this big ovicral suture. We use 4 of them to go around those bony segments and the tension laterally. The tensor tendon laterally, and this is, and then get a blunt retractor behind the palate, kind of pull it forward. So when you actually tie these, you're tying them under just no tension. And it's quite amazing when you look pre and post how much of an effect it has on the anterior posterior dimension. But I think part of what this also does is it actually pulls the palate up some. It actually kind of shortens the airway vertically. We've not done a lot of measurements on that, but I do think that that's part of the role of this, of part of what it does, is it creates more of that lateral wall tension. So although we think of this as just affecting the anterior posterior part of the airway, that's not true. Once you pull this up, the posterior flap's a little bit thicker than anteriorly, so you trim a little bit. But I always trim the mucosa, trim the fat first. And the last thing I do is trim any mucosa, because oftentimes you don't have to trim any mucosa at all. You just pull it up into the defect. That's my experience. So
Tucker, I might also get you just in the next 2 or 3 slides to comment on some tips and pitfalls. If you can vary them according to what you're doing these days. I know now we're starting to, I don't know if others are as well or you are as well, we're starting to use the piezo electric drill, and that really minimizes the gap that you create around a bony island. It just makes it fit beautifully now. And I think it's probably going to ultimately reduce fistula rate by not having such broad areas of bone drilled down to get through. So I really like the piezo now, but maybe this just shows a couple of different incisions. Maybe we can just skip to the next slide and Tucker can.
Yeah, this one shows, so initially we described kind of a Gothic arch, which actually extends probably 10 millimeters anterior to the greater palatine foramen, and then a midline incision up in front, and you elevate 2 lateral flaps as well as the posterior flap. And then the posterior flap kind of fits in between the 2 lateral flaps when you close it. Richard Lewis described more of a propeller incision that puts the tip of the flap kind of right between the greater palatine foramen, which is right over your osteotomized segment. And so some folks are a little more nervous about that, since if there's any dehiscence at all, your tip of your propeller is right over the osteotomized segment. But this works well because sometimes you get a little necrosis at the tip of the flap with the Gothic arch sort of shape. That anterior mucosa is quite thin, and it's actually not unusual that you get a little bit of a duskiness to that, and you actually get a little necrosis of the tip of that flap. So you end up having a little bit of a wound over your ballooning osteotomy anyway, even with that flap sometimes. So that's the advantage of the propeller, is that it's really a much thicker tissue at that point. I think it's a matter of somewhat personal preference and experience. I'll use both in different patients. I think the Gothic arch flap is great for the patient. It's like this diagram, has a nice wide palate, which is actually the initial patients I would do this on. I think the propeller incision comes into play, especially in the patients that unfortunately have maxillary constriction, which is the people with high arch palates. And then, those are a lot more difficult, and the propeller might be a little bit better there.
I think I agree with that. I think I've started to, when they're very broad, wide palates, do a Gothic arch, and when they're high and narrow, do a propeller incision. I know Richard Lewis does all propeller incisions, and his data showed a lower fistula rate, but we found that all the fistulas really were in high, narrow arch palates. So you can modify your incision probably according to the anatomy. Can we go to the next slide? I don't know if you want to make a few comments here, Tucker. I mean, the main point for everyone who's not done this before is unfortunately point number 2. You can't get to do the course this year. So that's the plug for 2022. If you haven't done one, it's really infinitely better when you've done one on a cadaver first, and you can understand the anatomy a lot better that way.
Yeah, exactly. I think that's really important. I think it's important to probably get. It's hard in a 2-minute video to see all the nuances of the technique, and I think it's really helpful to have the experience. Yeah.
We could go to the next slide. You do need to make sure, I don't know what you're using now, Tucker, but you really need to get those 5/8 needles in my experience, to get around. Otherwise, you've got to bend the needle to get it around. So you've got to get those O-vicral on a 5/8 needle.
And you can, if you don't have access for some reason to the 5/8, you can get a needle and bend it, or you can get a free needle. They actually have a 5/8 needle that's one that you can thread on your own, and just take your suture and put it on that threaded needle, as well as if you don't, because you really do need that curve. It makes it makes it 100 times easier, and so you don't need that extra struggle, because you end up tearing tissues and creating problems. Also beware, I usually pass the needle with the blunt end first, because the nasal turbinate is right on the other side of your where you're passing the suture, and you hit the turbinate with the sharp end of the needle, and then it bleeds, and you have to use a suction cautery, and it can really get quite annoying, that bleeding from the inferior turbinate. So try to avoid that.
There's a question there, Tucker, from Ahmed about possibly substituting dorsal flap pharyngoplasty for vertical palatal collapse instead of transpalatal advancement. I guess my only worry about that would be you'd want to get it perfect and make sure you don't make the palate go the other way if you're too bulky on the palatal side.
What we found is that the dorsal flap and pulling the mucosa in the operating room looks great. Unfortunately, because it's just a soft tissue, that tissue stretches back out, and when you look at the patient, down the line over a little bit longer term period of time, it just doesn't have the same effect, unfortunately.
Slide, thanks. So that's just, I guess, just the summary about when to use this. When you've got this compromised airway that Tucker's so eloquently described there, both today on this discussion and in the past in all of his pharyngeal anatomy publications, where we think it's not going to be adequate, when we think the patient is not going to tolerate maxillary advancement necessarily, because it's a reasonably aggressive procedure. And slide. It's a reasonably aggressive procedure because sometimes this happens, Tucker.
Yeah, the palatal fistula can break down. It's very treatable, but it requires patience, and the patient needs to be aware it can occur. And usually, what we do is make a little dental splint that can cover this. You can get your dentist to make a little clear splint that helps to cover it. It doesn't have to cover the whole thing, and you can do just in the office some serial closures. We've actually had palates that had complete dehiscence of the whole flap that, given a little bit of time, will heal up. It's frustrating, and you need to get the patient through it and get them the splint so they can continue to eat and function normally. It is a concern with this procedure, and you do have to be aware that it can happen. Absolutely.
Slide. But as Tucker said, it can heal up and it'll granulate ultimately. You just got to be patient, and unfortunately, the patient's got to be patient as well. And you'll transition from using a dental splint at all times to using a dental splint just with meals, and then slowly get rid of it altogether when it hopefully heals up. So,
and it really is, the splint's just critical, and they just need to use it. And if you're just patient, it's amazing. They'll heal up. But you can use in the office, do some deep sutures, not superficial, not just the mucosa. The tendency is to want to get in there and try to fix it right away. And it's going to heal by secondary intention from the lateral aspects forward. And doing more suturing actually probably causes more trauma to the tissues. You just have to kind of let it heal secondarily.
I think Offa's just mentioned there that he avoids patients with vascular disease and smokers, and I'd pretty much agree in principle with that Offa, although when Lyndon Chan published our data on that, it all came down to really how high and narrow arch the palate was as to your risk of fistula, but there just wasn't enough numbers to prove that smokers and people with vascular disease also get these issues. So
I think the diabetic vascular disease smoker, I mean, with high arch palate is not the first person to do this on that patient. You may want to consider even something more like just the whole MMA and go a different approach.
Yasin's asking about feeding. Actually, Yasin, it's if you're doing it with concomitant modified variant of U3P, you'll basically, most of the pain and discomfort comes from your tonsillectomy. So the transpalatal advancement itself does not impact swallow or eating and drink, straight back to normal diet as quickly as you can get them to go, really. You've closed the mucosa over the top of everything. So whilst it's technically fiddly and it's more difficult for us, it's not the major component that affects pain and swallow dysfunction early on afterwards. So we're probably finished a bit early, and I'll just invite, has anyone got any other questions for any of the panelists about any of the techniques that we've discussed here today? So anything about BRP, anything about expansion sphincteroplasty, anything about mod U3P or transpalatal advancement?
I know there's been a lot of discussion online with the different suture materials. I know we struggle with getting the right suture materials for the barb suture technique, which I think is a great advance. Claudia, you're going back to doing the double throw around the muscle versus a single throw for reducing dehiscence. Is that correct?
Yes, that's correct. It doesn't matter anyway. The matter is not the material, the number of the turns on the rounds, but the key point, in my opinion, in my experience during the last few years, is the brand. Now we are working with VLOC 19 and VLOC 180. We don't use any more Stratafix. We had a long discussion last time in Orlando, you remember, and Stratafix proves to be too rigid and not suitable for adapting to a soft palate. It's at the end you have a higher rate of distortion, and so I don't use anymore this type of suture. And I'm moving more and more from bigger to smaller threads. Now I'm working with 3/0 and 4/0 VLOC, and I feel much more comfortable.
I also noticed you made your relaxing incision a little bit in the lower pole of the tonsillar fossa. You made it not at the level. Do you feel that's an important technical variation, or do you think you could release the muscle anywhere in the fossa?
It's a good point, because I could see the picture, the paper that you publish, your co-worker publish, and so I try to use this variation, but I had to come back again to the lower incision, close to the feet of the posterior pillar, to the palatopharyngeal muscle. I feel more comfortable because I don't change the shape of the arch of the palatopharyngeal muscle. Anyway, I tried. Is an interesting technique coming from your group, and I think that is was to be attempted.
I'm not sure which is better. I mean, I think that it may be better going lower. You know, we're trying to reposition that whole muscle and change the tension in the whole pharynx. It's a complicated area.
Claudio, didn't you initially describe 2 or 3 releasing incisions down at the? You did more than one releasing incision usually that you originally described.
Yeah, we initially started low because we developed the whole pedicle, like Yasin showed, the longer pedicle going up. And then as time has gone up, we've kind of shortened the length of the pedicle. And a little bit longer pedicle may actually be better when you look at, because you have to look at it. We tended to start looking at the airway too much in just an anterior posterior perspective, but really you have to think of the palatopharyngeal muscle as the whole length of the muscle going all the way from the hard palate down towards the larynx. And you want to stabilize the length of the muscle, not just the cross-sectional area of the muscle. I have a question on the Australian technique that I've always wondered about. What do you do for the, you know, some patients have a really deep distance from the posterior pharyngeal wall to your anchoring point for the modified Australian technique. What do you do for the patient, though, that has a very narrow anterior posterior distance? Do you use the same technique, or do you modify it in some way?
Yeah, I'll usually use the same technique, and I'll just vary the degree that I pull up towards and how far I come up towards the tendon usually, and so you know, it just depends on what it looks like and how it feels. And so I like to get the registrars and the fellows to have a before they tie their knot, to have a pull and see what plane they're pulling in and see how it feels before they secure the knot. So I'll just vary it according to the anatomy. I think there's is there a question? What have we got? Someone's got a question about capso. I don't know if you want to comment. I presume they're talking about Kenny Pang's capso, the anterior palatal surgery. I know if that's what you're talking. In my experience, I found that the patients had a fair bit more globus when you got that real anti-version of the uvula. I only did probably about 2 or 3 of them many years ago and sort of stopped doing it. Has anyone else on the panel got any experience with capso?
No.
Not a lot. And it does bring up the question is, what's your go-to technique for kind of, in a sense, the mild apnea? I won't call it the simple snorer. I don't think there exists a simple snorer. But what's your technique for, you know, the mild apnea patient that doesn't want to use an oral device? You know, that you're going to do it, maybe look at a palatal technique. Do you have a go-to for that?
Yeah, I mean, it's the hardest patient to treat, because you almost, some of them with their based on their anatomy, you almost wish they had more severe disease, because you're talking about an anatomically guided operation that might be complicated enough to create some risk, but might not be warranted for the degree of sleep apnea in terms of that risk. So, but the patient wants it for symptom control. And I often in those times, I'll just discuss an array of things, and I'll usually land on a sort of workhorse like a modified Australian U3P and say, look, the predictability is just not as good as it is with other people. You know, that's usually where I'll land. But I find that patients, Tucker, I find that the patient preference component of operations comes very, very strongly into all of this. And I think we have to accept that as that third tenet of evidence-based medicine, that patients are going to have strong preferences about what pathway they take, and also in some cases what input they have into the type of procedure that they have as well. We're sure we're there to guide them, but they're still going to have strong opinions, some of them. you've got a question. What's Richard Lewis has written in? Can you unmute and ask us your question, Richard, or are you?
Can I ask Claudio Vicini? Sometimes after barbed reposition, pharyngoplasty, you find the central part of the palate still soft, and the patient, in spite of great improvement in the apnea, but still have some snoring. That's why we do from raphe to the other raphe by the same needle to stabilize the central part of the soft palate. What do you think?
We had the same in our first cases. As you know, now we change it a little bit in order to introduce a running suture from one raphe to the other raphe, interweaving along the midline in order to stiffen the midline. It's completely right. If you address mainly the lateral wall, you will have good results in terms of sleep apnea, but you may have a residual snoring because along the midline, the palate remain floppy. And so you have to do something in order to address. What we do more commonly is to pass more suture from right side to the left and from the left to the right in order to build up a network that is a maxi pillar technique around the midline. It proved to be much more helpful in order to reduce, to prevent the residual snoring. So we had a lateral addressing technique with a midline technique. It's a very good point.
Thank you.
I think there's also a question about BPI, nasal regurgitation, nasal reflux, and I think what we've been espousing for many years now still rings true, and that is the newer variations that we do are less likely to create that problem long term. They still have some transient or temporary issues, but the old resective type stuff was bad for that. And the only time I've had permanent VPI for many of these procedures is where I've tried to correct old bad type of surgeries with newer variants if I had no choice other than to do that. Probably what's more complex, I think, for these patients is globus and temporary and long-term globus after these surgeries. The problem that I find with it, I don't know if the panelists are the same, is that the majority of the people who are failing CPAP and device use for various reasons related to having something in their mouth are also the same people who will obsessively focus on a globus sensation post-operatively. They're the same people, if they had an appendix scar, they'll feel the appendix scar forever, or a thyroid scar, they'll feel it forever. And they're the people that you get backed into a corner and that potentially have to operate on, but they're the ones who'll also tend to focus without desensitizing their globus and getting over it in a sense after the operation. Do you find that as well, Tucker and Claudio and Yasin? Or?
Yeah, the globus sensation, you're right. I think that a lot of people will experience the globus sensation, and you're right, that there's a subgroup of people. So I think that sensation is probably more common than we attribute it. And then the people who are more anxious, who have more somatic concerns, will continue to complain about it. I think some of the people that don't complain about it still have some of that sensation. They adapt better. I wish I knew the etiology of the globus. It seems as though we can do a horrible tonsillectomy and people don't get the globus sensation, but you do what you think is a perfect palatal pharyngoplasty and it happens. I think if you lessen the damage to the uvula and the nerves that go to that portion of the palate, that you lessen the globus sensation. So I try to do as minimal modification as the UV as possible. But in many of these patients, that's not possible. They have these massively damaged uvulas. And really, I think you do have to reduce it, but I try to avoid eliminating it. I try to preserve at least a portion of the uvula in most patients with the goal of reducing the globus.
I think Offa wants to join in and make a comment about globus. I think Offa, the problem with informed consent is the more you talk about globus to particular types of people, the more they're going to focus on it afterwards. It's a catch-22 between telling them that it's a risk versus not telling them and not advising them the risk.
Right.
When you tell them, they obsessively focus upon it because you've informed them it's a high chance of happening.
I think that it's important to include it in the informed consent, at least in my experience. And the other thing that I would like to mention is that we need to think about potential ways to reduce pharyngeal irritation after surgery. And this is something that I picked up from my partner, Jonathan Aviv, that there's a dietary issue that so many of our foods actually are very acidic in nature and can cause vagal or glossopharyngeal nerve dysfunction, literally. And so there's a whole list of them. And, apparently, for example, in the United States, anything that's bottled or canned is actually acidified by law. And so there's a role of actually the post-operative diet that can be actually quite important in potentially minimizing the inflammation, the desensitization of the sensory nerves of the pharynx.
Well, good point. I mean, you come from the area, I think, where the literature has proposed that for Globus in general, we should, rather than use anti-reflux agent, be focusing on dietary modifications, subtle alkalinized water, all those avoidance of excessive throat clearing and all those sort of good vocal hygiene tips. And maybe we should be giving them to patients pre-operatively so they can get straight into it afterwards. We've got probably only a couple of minutes left. I think Richard Lewis, are you unmuted, Richard?
Yes, I am, Stuart. Can you hear me?
Do you want to join in with some comments about the anatomy and what you've been noticing lately?
Yes. Can you hear me?
Yes.
Yeah.
Well, thank you very much for your excellent presentations, everybody, and discussion. I just wanted to talk about palate length and any attempts or thoughts on standardizing or adjusting the height of the palatal arch. I often, before starting a modified UP3 with the patient anesthetized, just take a moment to look at the sort of apex of the palatal arch in relationship to the maxillary tuberosities and the posterior molar teeth on the lower jaw, and just assess in my mind whether it's a sort of a low palatal arch below the midpoint between those points, or whether it's above the midpoint. And I try to adjust the angle of my palate incisions to either raise that arch up to a degree or leave it at approximately the level that it is. Is this something that you guys all consider or play around with during your modified UP3s?
I've wondered about it as well, Rich. It's almost analogous to, the difference between saying you've got a bulky tongue based on just what size it is, as opposed to whether it's, looking into more detail, is it above or below the occlusal plane? Is it the palate that's hanging down behind the tongue? That's the reason you're calling it a Friedman tongue grade 3, rather than the tongue itself being bulky, and all those sort of factors. There's a lot more to it, isn't there, really?
Yeah, I mean, I get the sense that where the sort of the summit of that arch is below the midpoint between the maxillary tuberosity and the retromolar trigone, it's a long, soft palate, and I intuitively just raise it up. Now, I don't have any data to support whether or not that gets better outcomes from a modified UP3, but it might be worth considering. A longer part of, when it gets back to what Tucker was talking about with his description of the anatomy of the soft palate, I think, and it's just something to consider, and perhaps we could look into it.
And as Tucker said, they're probably the ones in platal advancement that you're actually pulling the palate more anteriorly, Richard. If they're broad across the hard palate, that apex is down low, and they're still vertical, you're probably pulling them anteriorly as well.
You are, and Tucker made a good point too. When you do advance the transpalatal advancement, you do see the palate elevate too superiorly. It moves superiorly as well as anteriorly.
Yeah, which is something I didn't realize as much. And my concern about doing with the soft tissue techniques is you don't want to bulk up the palate. We actually saw with some of the earlier expansion techniques, when we shortened the palate just with expansion by itself, is that we actually saw that the ventral palate would actually get thicker and actually compressed, you'd see a narrowing endoscopically, the anterior posterior distance in the retropalatal airspace would seem to get smaller. So you'd actually open up the lateral walls, but the anterior posterior distance would actually get smaller, I think, because you're shortening and bulking up the palate. And so I'm not sure that the best way always to deal with that. I think that's something that is especially we can discuss and further. I'm not sure the answer to that.
Might be worth playing around on some cadavers. We might have to think about calling it there because we're coming to the end of the session and Tucker's glasses are moving higher and higher up his cranium at the moment. So I know that means he's starting to fatigue. So thank you. I thank you all for your input and everyone for their participation and questions. And thanks in particular to Tucker, Claudio and Yasin. And look forward to the rest of the sessions and tomorrow's sessions.
And Stu, I echo your thanks. Thank you for putting together this panel. I want to point out this panel, because of Zoom, came from 4 continents in the world, which is outstanding. The presentation was excellent. We gave the palette the longest presentation time because there's always a lot to discuss. I was surprised, though, Ofer, that we didn't hear from Bob Jones during that presentation. So maybe he'll come up soon in some other future presentation. So we're going to move to the Netherlands, Amsterdam. Nico de Vries and his colleagues there have put together an excellent panel on positional therapy for obstructive sleep apnea. We're going to begin in about 2 minutes, so I'll give everyone a break. We want to start exactly at 10 minutes after the hour, so we've got a 2-minute break. We'll play some slides here at the Nicholson Center, and I'll be back in just a few minutes.
Good morning. For the coming 30 minutes, we are going to look at OSA from a sleep position perspective. Our group in Amsterdam has performed a lot of work in positional therapy. In terms of disclosures, we need to mention night balance, now Philips night balance, but my role for now is to introduce you to 2 fantastic speakers. Madeleine Ravensloot will talk about diagnosis and positional OSA. Peter van Manen will talk about positional therapy. One thing that I want to convey is how common positional OSA is. Particularly in mild disease, more than 50% of patients is positional. With increasing disease severity in moderate and severe OSA, the number of events goes up in other sleep positions as well. And this phenomenon is reversible. After partially effective OSA treatment being upper airway surgery, upper airway stim, MADs, MMA, weight loss after bariatric surgery, you will often see that severe non-positional OSA reverses to less severe positional OSA. For those of you who cannot get enough of it, there's a whole book about positional therapy from our group. And having said all this, I'm now going to give the word to Madeleine. Thank you very much.
I want to start off by thanking the organizing committee for the kind invitation to speak at this terrific conference. I am impressed that despite all the hurdles Corona throws at us, that you have managed to set this great complimentary virtual conference up. Nevertheless, I do hope that we can all be together and meet in person next year. In the meantime, in Holland, one thing that's the same as the last meeting I attended in 2018 as a faculty member, Holland has become a skating rink and everyone has pulled their skates from the attic to enjoy all the frozen lakes and canals. This is not how I go to work, but it does seem like this on the lakes in this area. So I've been asked to give a presentation on positional sleep apnea and in particular the diagnostics. The instructions were very clear, not too much theory, keep it practical, which is what I'll try to do. So over time, studies have portrayed sleep apnea as a multifactorial illness. Eckert and his colleagues have described various physiological mechanisms, such as high loop gain and low arousal threshold, alongside anatomical collapsibility. Eckert focuses on physiological mechanisms with potential clinical application. However, differences in characteristics between non-positional and positional patients suggest another crucial phenotype distinction, a clinical phenotype with already existing clinical application. In these so-called positional patients, the frequency and durations of apneas are influenced by body position, and it's important to realize that this is nearly 3/4 of the patients with obstructive sleep apnea. The difference is clearly illustrated in these polysomnograms. This is a non-positional patient. In blue, continuous and severe desaturations. In red, significant cyclic variations in the heart rate. In black, constant and loud snoring. And in purple, a high number of apneas and hypopneas, which appear independent of the body position, which is illustrated in dark red at the bottom. This is the PSG of a positional patient. The desaturations, the cyclic variations in heart rate, the loud snoring and apneas appear almost exclusively in the supine position. The prevalence of positional sleep apnea decreases as the severity of sleep apnea increases, which is clearly illustrated in the following slide. 70 to 80% of positional patients have mild or moderate sleep apnea, whilst only 30% of patients with severe sleep apnea have positional sleep apnea. Furthermore, we know that there's an inverse relationship with the BMI. We know that there's a prevalence of positional sleep apnea that's higher in the Asian population, and patients tend to be younger. The most common worst sleeping position is, in nearly 3/4, is the supine position, so lying on your back. If you look at the anatomical phenotypes of these positional patients, various studies have used a variety of diagnostic modalities in awake patients and have suggested that positional patients, in comparison to non-positional patients, have a more backward positioning of the lower jaw, a lower facial height, longer posterior airway space measurements, and a smaller volume of the lateral pharyngeal wall tissue, and therefore a greater lateral diameter and an elliptoid shape of the upper airway. The current hypothesis is that even though the anterior-posterior diameter in both positional and non-positional patients is reduced as a result of the effect of gravity in the supine position, due to the greater lateral diameter in positional patients, there is sufficient preservation of airway space and avoidance of complete upper airway collapse. So how do we define these patients? This is Rosamund Cartwright, who unfortunately passed away just over a month ago, but she was the grandmother of sleep, as it were. And she was the first person in the 80s to describe criteria to define these positional patients. And she said that if patients had an AHI was twice as high in the supine position to the non-supine position, then these patients could be considered positional. In the meantime, there have been various modifications described in the literature, and the main additions are cutoff values for the AHI in non-supine position and time spent in the various sleeping positions. When looking from a clinical perspective, I definitely recommend the APOC criteria, so the Amsterdam Positional Sleep Apnea Criteria. First of all, it's important to state whether a patient has obstructive sleep apnea. And then it's important to think about how long a patient has slept in a certain position. And we defined a minimum of 10% in the supine position. First of all, if the patient has slept too shortly in a certain position, you can ask yourself whether the measured respiratory indices are reliable, are they valid, are they representative? The second theory is that patients with a very severe sleep apnea in the supine position self-correct. So they've learned to not lie on their back. That's a really bad idea. And then you've got the question about the clinical relevance. You know, if somebody spends 1% of the night lying on their back, even if you train them or help them with a positional therapy to not lie on your back, they're not going to achieve much. So therefore, we said they need to have a minimum of 10% of the total sleep time in the supine position. Then we define the first category. If a patient has an AHI in the non-supine position or the best sleeping position of less than 5, these patients could theoretically be cured by avoiding the supine position. Later on in literature, it's also being called supine exclusive or supine isolated positional sleep apnea. We call it APOC 1. The second group is patients who have a lower OSA severity category in the non-supine AHI, supine position, in comparison to the total AHI. Therefore, patients get new treatment options and they can receive maybe a combination therapy or less aggressive surgery, less aggressive treatment with a mandibular advancement device if they're able to avoid this supine position, which aggravates their sleep apnea. Last but not least, we have a third category where we see it as a more salvage therapy, for example, to be able to reduce the pressure of CPAP and therefore make it easier to remain compliant. So in a nutshell, who are these suitable candidates? Clinically significant improvement of the OSA with positional therapy. And the true POSA patient can be cured by positional therapy alone. So that's the patient with an AHI less than 5 in the non-supine position. Then you've got the non-positional patient who will not benefit from positional therapy. And then you've got the multifactorial patients who can benefit from positional therapy, but it cannot be curative and probably not as a standalone treatment. This is a schematic version of what I'm trying to describe, because you can divide the OSA patients into two groups, the positional patients and the non-positional patients. And then the positional patients can be further classified as supine predominant, whereby the respiratory disturbances are mainly in the supine position, but they have persistent respiratory disturbances in the non-supine position. And then you've got the supine isolated OSA, whereby the respiratory disturbances normalize in the non-supine position. And OSA patients who have an increase of breathing abnormalities while sleeping in the supine versus the lateral position are considered positional patients and suffer from positional sleep apnea. This is another way of showing it, right? So the supine isolated patients, they have breathing abnormalities during the night, but when they're not lying on their back, they have an AHI less than 5 and therefore could be cured by positional therapy. Now, if you look at this graph, which is a graph from a poster presentation by Dr. Heinze from the CHUV in Lausanne, Switzerland. His group does a lot of studies on positional sleep apnea. And they performed a large population-based cohort study. And this graph represents the prevalence of positional sleep apnea stratified by a minimum AHI of 5, 15, and 30. And the blue columns represent POSA defined by Cartwright's criteria, and the red columns represent the true positional patient with an AHI less than 5 in the non-supine position. And as you can see, a third of the total OSA population were true positional patients, whilst only 5% of the patients with severe sleep apnea were true positional patients. So what about PSG and body position? Well, what's important to realize that in particular, in positional patients, the severity of disease is entirely dependent on the severity of the disease in the various sleeping positions, and even more so on the time spent in the various sleeping positions. The longer a positional patient spends in the supine sleeping position, the greater the severity of disease and vice versa. So sleeping position changes during sleep are considered a critical factor contributing to night-to-night variability of OSA severity, with a significant impact mainly among positional patients. So during PSG, you can imagine that with all the apparatus that is applied to these patients, you might think that patients, especially patients who like to lie on their stomach or on their chest, that they start sleeping differently than they normally would. And studies suggest that patients spend a third more time in supine position in comparison to normal sleep. So the apparatus strapped to the chest probably plays a role. And again, this is of particular importance in positional patients, whereby the increased time spent in supine position may cause overestimation of disease severity. And this is important for both your clinical practice and research. One must keep the possible increase in percentage of total sleep time in the supine position during PSG and subsequent impact on OSA severity into consideration. So if you've got a patient and you're looking at the efficacy of your surgery on his OSA, if the patient initially spent very little time on the supine position and on the second PSG, a very long time on the supine position, this might be one of the reasons patient has results that are not as great as you had hoped for. So again, this is the graph showing on the left side the percentage of the total recording time of a patient when he was undergoing a PSG. And on the box on the right, it shows what happened when patients were wearing a positional therapy device that was not on. So patients were less likely, as you can see, a third less likely to lie on their back during normal sleep than during PSG, which therefore influences the AHI as shown in the right box. What about DICE and body position? Well, historically, it's been the case that it's always we always perform DICE in a supine position. It's easier. It makes it, it's a lot less complicated. But nevertheless, we know that observations during DICE differ significantly in the supine versus the non-supine position, and in particular for positional patients. Originally, it was thought that just changing the head would be enough, but it's not. You really need to start with your patient on the side. It's the easiest way to do it. Once you've done your observations and you've filled in you've managed to see everything that you want, you can flip the patient onto his or her back to see what happens there. This may change your treatment plan as far as surgery is concerned. And, it gives you also information about patients who, in position patients, what the residual Ds would be despite positional therapy. So I really recommend in your positional patients to perform a DICE on his or her side and then flip them onto their back. Another consideration is that head position influences OSA independent of the trunk position. So this isn't the case in all patients, but in a study of 300 subjects, 41% of the cases were not position dependent, 52.3% were supine position dependent based on a trunk sensor, while 6.5% were supine position dependent based on the head sensor alone. And in 46% of the trunk supine position dependent group, head position was of considerable influence on the AHI. So the AHI, despite lying on your back, if the trunk and the head were on their back, it made the sleep apnea even worse. This is illustrated in this polysomnogram where you see that the apneas, they take place in the supine position, but not continuously. And this is due to the fact that the patient does or does not have his or her head placed in a supine position as well. I didn't have a lot of time, so I really had to give a superficious, presentation on the diagnosis of sleep apnea, but I hope this has been some help to your clinical practice. Two things I want to mention. First of all, if you would like to stay up to date on what's happening in the sleep surgical world, don't forget to become a member of the International Sleep Surgical Society. Follow us on Instagram to get regular updates. And these are two articles that I recommend as a read, which give you more information on the efficacy of new generation positional sleep apnea devices or positional therapy devices. And second, an article that we recently published introducing a standardized framework to report on the role of sleeping position in sleep apnea patients, which also gives a thorough review of many different topics of body position, which is relevant for both research and clinical practice. I'll pass the microphone on to Dr. Vermaane.
Dr. Avensloot, and thank you, Dr. De Vries, for your kind introduction, and a big thanks to the organizing committee for giving me the opportunity to talk here about positional therapy. I'm Peter Vermaane. I have nothing to disclose. And first, I'd like to briefly talk you through about the history of positional therapy. So Sullivan, and it's a different one from CPAP discovery, was the first person to patent a positional therapy device. And it consisted of a vest with a bulky mass on its back, and it was meant to prevent people from sleeping on their back by putting this bulky mass there. And that type of therapy has been repeated over times for many years. And even up until recently, this was a quite common type of therapy to use when we wanted to recommend people not sleeping on their back. And this was referred to as the tennis ball technique. And all kinds of bulky masses have been put in one's back to prevent one from sleeping in a supine position. What we know, however, from this therapy is that it is a very uncomfortable treatment option because patients find it cumbersome to move from side to side and then having to come across this bulky mass in their back. And it was shown that the long-term compliance of people using this technique was less than 10%, mainly because it disturbs them in their sleep quality. And this is when OLVG, the hospital Dr. De Vries, Dr. Raafsloot and I work in, started focusing on positional therapy. And this was the first device we ourselves developed in our hospital. And it had to be put in one's neck, and it consisted of a small mobile phone battery, a positional sensor, and some batteries. And it gave a small vibrational stimulus when one was sleeping on its back. And it worked well, but as you can see from the picture on the right, it doesn't look very attractive. So we stopped further developing it, also because we came in touch with night balance. And we then focused our research topics on the effectiveness of the sleep position trainer. Nowadays, it's called the Philips Night Balance, by the way. And what it is, it's a small strap that one has to wear around his chest, his or her chest, of course. And in this strap, there's a small device that's able to monitor one's position, and it's able to give a small light vibrational stimulus to correct one from sleeping in supine position. Also, it has readout options, so a person is able to see how many hours he or she has been using it, how often the device was giving the stimulus, etc. And this device was shown to be an effective treatment in a group of approximately 30 patients that we followed up for a month. And here you see the baseline characteristics and the effects of the treatment after 1 month with the sleep position trainer. And you can see a clear AHI drop and also, of course, percentage of supine sleep time drop. All values here, by the way, are median with interquartile ranges behind it between brackets. And even though it was a very short period of time, only a month, we were also able to show effects on subjective complaints as reported in the ESS and the Functional Outcomes of Sleep questionnaire. Michiel IJsvogel, a Dutch pulmonologist, showed that this treatment was as effective or even a bit more effective when compared to the tennis ball technique in preventing one from sleeping in supine position. And he also did a study with a follow-up of a month. It was then necessary to show if the results of this treatment were also able to have a more prolonged effect on one's percentage of supine sleep time. And that's what we did in this study, in which 18 Dutch hospitals were including patients, and we had a follow-up of half a year. And in this group of 120 patients, we were able to show the effects of the sleep position trainer on a percentage of supine sleep time and show that the effects remained also during half a year of follow-up. Our group, and more specifically Linda Benoit, also did a randomized clinical trial in which mild to moderate positional OSA patients were prescribed a sleep position trainer and oral appliance therapy, and she showed that the effects of both treatments were the same when looking at AHI and also when looking at subjective outcomes. She also looked into adverse events of both treatment options and saw that oral device treatment had more adverse events and more various adverse events than the sleep position trainer therapy group. Another very interesting research was done at Antwerp University Hospital with Olivier van der Veken's group, and Marijke Dieltjens wrote this very nice article on residual OSA after or during oral device treatment. So Antwerp University does a lot of research on oral device treatment, and they saw that quite often OSA patients who were treated with an oral device suffered from residual positional OSA whilst under oral device treatment. So what they then did was prescribe them a sleep position trainer and compare the effects of the oral device to the sleep position trainer, and they saw that the effects were the same. And then they decided to combine these treatments and saw that the effects of the treatments combined was greater than both single treatment options alone. And that's also something we found when looking into our OSA surgery data. Quite often we would see that our success rates were higher in our non-positional OSA patients when looking at palate procedures, tongue-based procedures, but also when looking at the maxillomandibular advancement surgery. And we saw that quite often non-positional OSA patients became positional OSA patients, and that the effects of our surgeries was greater in the lateral than in the supine position. And we hypothesized that positional therapy could improve overall response to treatments and to surgical treatment. I now briefly like to talk to you about the positive study, one of the more recent studies on positional therapy. And this research was performed in the United States, and they looked into exclusive positional OSA patients and randomized them to either the night balance, the Philips night balance, or the auto-PAP treatment. And this way they looked at approximately 55 patients per group. And they looked at adverse events, and they looked into compliance and treatment preference. And as you can see in this table, positional therapy had less adverse events when compared to the auto-PAP, and it looks quite similar to the study I showed you a bit earlier on oral device therapy, in which oral device therapy had significantly more side effects than the positional therapy group. Also, they saw that when looking at the average nightly use, positional therapy was used for more hours per night when compared to the auto-PAP treatment. And they concluded that treatment with the sleep position trainer resulted in a non-inferior treatment efficacy and greater adherence compared to auto-PAP in positional OSA patients, suggesting that sleep position trainer is an effective treatment for this group of patients. And that's also how I'd like to conclude this talk. Positional therapy is an effective and well-tolerated treatment with very little side effects for positional OSA patients. It can be used as standalone treatment or in addition to CPAP or oral device or upper airway surgery. Thank you for your attention.
So in sum, positional OSA is relevant both for diagnosis and treatment. In the diagnostic phase, always check for position. It's relevant for PhDs and DICE. Positional therapy has shown to be effective, usually well tolerated, so it has a lot high compliance, it is reversible, it has no effect on sleep quality, or if it has, it improves it. There are no important side effects, and the costs are acceptable. On behalf of my group, thank you so much.
Nico, Madeline, Peter, thank you very much for the panel. I think it's very useful to hear this non-surgical treatment for obstructive sleep apnea. I see that, Madeline, you've been answering the questions on the chat. If you can continue keeping up with that, we're going to move on to the next panel. Nico, you are also the moderator for this next panel. It is on DISE, drug-induced sleep endoscopy. So we'll move right into this panel with Nico de Vries, Paul Hoff, and Eric Kuhler.
Good morning. The coming 30 minutes will be devoted to DISE. What is DISE? DISE is short for drug-induced sleep endoscopy. When is it indicated? Well, the ideal patient is a patient who enters your office and asks, listen, the prospect of using CPAP the rest of my life is not very appealing. What are my alternatives? So then you perform your DISE. You look in the options for upper airway surgery, upper airway stimulation. And while you're doing it anyhow, you also might as well can look into what happened with the jaw thrust as prediction for oral device therapy. You can look in lateral position, positional therapy, and you can look for combined treatments. For those of you who would like to read more about, recently appeared this book on DISE. If you do it, you need a system, and many different systems have been proposed, but by far the most used is the VOTE classification system, in which we look at level or levels, configuration or direction, degree or severity of obstruction. It is an assessment only of the collapsible part of the upper airway, phylum, oropharynx, tongue base, and epiglottis. The phylum is the only part where all three types of obstruction can happen: anteroposterior, lateral, and concentric. Oropharynx is usually lateral, rarely also concentric. Tongue base is always AP, gravity, and epiglottis, especially primary, is almost always floppy, anteroposterior, and sometimes lateral, the involution. We then fill out the form as follows. You have the 4 levels. You fill out is the AP lateral or concentric. 0 is no obstruction, 1 is partial, and 2 is complete. Some boxes are not open because there is no such thing as a concentric epiglottis collapse, so you cannot fill that out. You do that at least 4 times. Supine with jaw thrust, lateral head, or preferably head and trunk, especially positional patients, and combined. DISE is not difficult. As we do it, the resident does it with a dedicated nurse practitioner. According to the European Position Paper guidelines, all DISEs are videotaped. The resident fills out her treatment recommendations, and I can check her or his train of thought. Special attention for floppy epiglottis. Patty Funk, resident, found out that she did a lot of DISEs, that she only saw a floppy epiglottis and the patient was supine. So in a series of 324 patients, she saw 60 floppy epiglottis cases. When we then performed the jaw thrust, it decreased to 10. When she turned the head, it was only 4. And when the patient was turned to lateral position, head and trunk, only 1 floppy epiglottis remained. So nice example how developments as dice and position changes lead to new insights. You can also use it before and after upper airway stim. This also has led to new insights, such as that opening of the palate after upper airway stim is usually as good as of the tongue base. Having said all this, we come to the introduction to our 2 famous speakers. First is Paul Hoff. Paul is from Michigan. He's on the board of the International Surgical Sleep Society. And together with his house officer, Pratyusha Yalamanchi, he has created a nice instructional DICE video. After Paul, Pratyusha, equally well-known person, Eric Tuller from Sao Paulo, will continue. Paul, the floor is yours.
Today we are performing drug-induced sleep endoscopy, or DICE. DICE is a sedated examination which demonstrates the dynamic collapse pattern of the airway under simulated sleep. DICE is not a substitute for a sleep study and should not be performed unless a polysomnogram or home sleep test has already been performed. The examination is recorded, and DICE provides an objective measure of specific sites of collapse. Both the direction and degree of collapse are recorded. The VOTE system has been widely accepted for the assessment of adult OSA patients. A VOTE score can be recorded, demonstrated on a white dry erase board that we will show today. DICE can help to guide surgical decision-making in terms of revision surgery, discordant exams, and consideration for hypoglossal nerve stimulation. DICE may alter the surgical plan in up to 50% of cases.
So I'm Dane from anesthesia, and we'll be doing a sleep endoscopy today. And our plan is to do a propofol induction. And there's several different options that we can do for induction and maintenance of anesthesia. We chose propofol today because it best simulates a natural sleep, sometimes combined with propofol and midazolam. And in terms of our induction, we're going to give a bolus and then have a constant infusion going. And there's 3 different main options for induction and maintenance of anesthesia. There's targeted control infusion, which we don't necessarily utilize all the time in the United States. But there's also manual infusion, which we can adjust our dosages, and it's per weight. And then we also have boluses that we can place in line in the IV and give our medications in that fashion. And again, we'll be titrating our anesthetic to until the patient starts snoring and not responding to voice. And our anesthetic considerations are in conjunction with the European consensus statement.
All right, so we are doing a sleep endoscopy on a mannequin today. And we're simulating this just to show kind of the maneuvers that we will use. And as you saw previously, how the sedation is induced and maintained. One of some of the key things is obviously patients in the supine position. We try and put them in a normal position that they would be sleeping in with a pillow. The room environment is very key. You want to have a quiet environment, just like if you're going to bed with the room lights dimmed, sometimes some light music going if the patient wants it, but anything to make them feel comfortable. And then once we begin, I'll typically do place the scope when the patient's wide awake and take a look just to get a baseline to understand what their anatomy looks like before they start to snore and when all the secretions start to begin once they're sedated, not swallowing. So then the scope is passed a second time after they're sedated, and as we were talking about earlier, having them with a BIS monitor, somewhere around 65 is when they're perfectly snoring in many cases, but that's very variable. But we also often use just It's called the modified Ramsey scale, where the patient is not responsive to verbal stimuli or light manipulation, and they're snoring. They have to be snoring when you're doing this. So typically, we have a fiber optic light, little fiber optic laryngoscope set up to a light source and a video camera. It's very important to record your exam so that it can be looked at later by both you or if you have any questions about your exam, that can be reviewed by an outside reviewer. And the scope, again, there's no local anesthetic in the nose, no decongestant. The scope, I tend to stand at the head of the bed, but you can also stand to the patient's right, in more of a traditional view. And the scope is just pass it into the nasal cavity, and you position the scope so it's sitting superiorly at the posterior coinus, so you're looking at the velum. That's the first area you're examining using the VOTE system. That's VOTE stands for velum, oropharynx, tongue base, and epiglottis. So you want to monitor those areas. You're looking for direction of collapse and the degree of collapse, and you can use a called a VOTE score, which is how we determine what kind of surgery you might offer the patient. And so those 4 areas are documented. You chart that, and after that's complete, the scope is removed, and the patient is either awakened, or if the patient needs some kind of a nasal procedure, it's a good time to consider doing a nasal procedure. The patient typically would have to be put under more general anesthesia at that point, and the patient be turned over to the anesthesiologist for that. But the patient's awakened, and then we talk to them in recovery about the results.
Hi, today we are doing a sleep endoscopy for a patient who has a BMI of 26.7 and severe obstructive sleep apnea. His AHI is 54.4 with a central index of 3.6. His oxygen nadir was 82% with a mean percent of 93. There was a positional component to his sleep apnea that we will be assessing today. So we started with the awake endoscopy and then proceed to the sleep endoscopy.
Here we can see the BIS monitor is 98, is wide awake. I just started sedation.
We're at 72 on the BIS monitor. We've started to do the sleep endoscopy because it can be stimulating, and ideally we'd like our BIS monitor around 60. We just start to get into position. Okay, one of the options to assess for positional apnea is to turn the patient's head to the right or to the left to see if there's a positional component. So essentially turn the patient's head to one side and assess, or again, turn the patient's head to the other side and also assess. Another positional maneuver that can be helpful can be to provide some jaw thrust for the patient, or to have someone else who can assist you in providing jaw thrust and seeing the effect on the airway.
After the sleep endoscopy, to record your findings using the VOTE system. This is the system that's been used in the European consensus statement on sleep endoscopy, and it's a nice standardized scale, and it gives us objective data. We look at different areas of collapse. We look at the direction of collapse, and we look at the degree of collapse in different areas. The velum, the oropharynx, the tongue base, and the epiglottis. And in each of these areas, we can come up with a score, direction, anterior, posterior, lateral, and concentric. In this patient's case, we found there was anterior posterior collapse, partial collapse with vibration, so we score a 1. And the oropharynx, we weren't really able to see that, so we scored that as 0 in all areas. base was very obvious, and that was a grade 2, like almost complete collapse. And we found that the anterior posterior collapse. So 2 8 and the epiglottis was a partial collapse with some. So that was in the anterior posterior direction, partial with vibration, so 1. So our score overall would be a 4. Add these together, so a vote scored 4. But you would, when you record this in your note, you would record it as velum 1 AP, oral pharynx 0, tongue 2 AP, and epiglottis 1 AP. That's how you score it. So to conclude our session on sleep endoscopy, it's important to know that sleep endoscopy is a very important tool for the sleep surgeon. It can change the surgical plan in up to 50% of cases. So that's an important thing. It's actually and it's always required for epiglossal nerve stimulator. One of the other important things to remember, though, is that sleep endoscopy is not a substitute for polysomnography or a home sleep study. Every patient who is undergoing sleep endoscopy should have already had a sleep study. And this is just a tool for the surgeon to figure out a surgical plan. Thank you very much.
Hello, everyone. I am Dr. Eric Tuller. I am a sleep surgeon in São Paulo, Brazil, and postdoctoral fellow at UPenn. I have the task to share some thoughts about drug-induced sleep endoscopy. I will follow a different path. I will try to discuss what evidence we have that goes beyond the site of collapse. I have 3 main goals. First, DICE role for oral appliance therapy, positional OSA, and positive airway pressure. DICE contribution to OSA surgery. And I will raise the discussion about site of collapse and versus mechanism of collapse. Starting with oral appliance therapy, there are some papers, this is one of them, showing that jaw thrust stimulation can improve selection, can predict the response clinical outcome to oral appliance therapy. And patients selected by this way in this paper, by jaw thrust stimulation, had better outcomes than patients selected using clinical, standard clinical selection criteria. Regarding positional OSA, this paper demonstrates that 95% of patients that had positional OSA, they improved both size and degree of collapse in lateral position during DICE. So we can, using this maneuver, we can have some information, additional information about positional therapy. We can also, there is another paper also showing that we can use head rotation to simulate the position change. We can follow the same idea using PEP during DICE, and we can we have papers showing that we can try to titrate, and the values in this paper obtained were similar to the in-lab titration, but we can also have additional information about the sites of collapse that are compromising the CPAP adherence, and so it can help to understand the low compliance. And what the literature demonstrates is that tongue-based and epiglottic collapse, as demonstrated in this video, are both associated with higher pressure and with lower adherence. What about DISE and OSA surgery? We have this large multicentrical study showing that patients that were submitted mostly to different versions of UP3, they presented worse outcome if they had in preoperative DISE, lateral wall collapse and supraglottic collapse. So both lateral wall collapse, as we see on the left side, and supraglottic collapse on the right side, were associated with worse outcomes. This paper did the same analysis using DISE previously, in this case through a lateral laryngoplasty, and could demonstrate that this procedure had better, addressed better the lateral wall collapse, but still hypopharyngeal collapse persisted and were associated with worse outcomes. What about tongue-based surgery? Interestingly, this paper demonstrates that DISE did not contribute to patient selection, and so both groups selected using DISE and using clinical criteria. They had the same outcomes, and so there is no evidence showing that DISE can improve selection for TORS or tongue-based and supraglottic surgery. In this case, it was used TORS for treating the patient. Regarding MMA, this paper performed DISE preoperatively to MMA and could demonstrate that this procedure improved especially the multi-level oropharyngeal collapse, so the velopharyngeal, oropharyngeal, and hypopharyngeal collapse occurring at the same time, as we see in the left side, and also could improve the pseudopharyngeal collapse. And the stability of the lateral wall, as seen on the right side, was a marker of success. But still, the tongue-based collapse didn't improve as much as the other side of collapse. The strongest evidence we have, or at least the most accepted evidence, is the presence of circumferential collapse in patients that didn't respond well to upper airway stimulation. This criteria was adopted as an exclusion criteria for this therapy. And so patients with circumferential collapse, as seen in this video, they are excluded from the implantation of this device. However, even excluding patients with palatal circumferential collapse, there are still some patients that they do not respond well, do not improve as expected. And this paper used an interesting strategy measuring titrating CPAP during DISE preoperatively, and they could correlate, they could find that patients with lower pressure, less than 8 centimeters, they had better outcomes with a predictive value of 85.7%. For me, mostly it helps to raise this final question: if both side of collapse and mechanism of collapse have the same meaning. This has been especially our research question, and what we see is that most of our patients with hypopharyngeal collapse has this type of collapse in association with mouth breathing, and chin lift or closing the mouth has a huge impact over the collapse itself, and it can change the size of collapse and the degree of collapse. Using this information for patient selection through TARS or tongue-based and supraglotoplasty, we could use this information to exclude patients for this procedure. We could achieve a high success rate. And if we look at the mouth using oral endoscopy at these patients, we will see that these patients that they were excluded, they have a tongue-driven collapse, or at least we realized that the tongue is not well supported by the upper jaw. And so we have been studying if there is a correlation between this type of tongue collapse and maxillary deficiency, premolar and molar areas. And we could find that there is a correlation, especially with the intermolar distance in tongue-based collapse. Patients with reduction less than 9.8 millimeters had more tongue-based collapse than patients with more than 34 millimeters. What I expect is our current research is try to understand further, especially how the tongue base, this mechanism of collapse involving the tongue, can impact airway using pressure and flow sensors, and try to understand better how we can use this information to improve patient selection for OSA surgery. Take-home message. DICE is useful to gather information for oral appliance therapy, CPAP, and upper stimulation, but the whole is not well established in improving surgical outcomes. Especially, we must keep in mind that the data refers to failures, and so these are not information that can tell us how to use DICE findings to select patients, but mostly to how to use these findings to exclude patients from our surgical procedures. Especially be aware with this mechanism of collapse involving the tongue. This type of tongue-driven collapse can be associated with maxillary transverse deficiency and will not be treated by some of our surgical procedures. Thank you so much for your time, for your attention. Be safe and be well.
Thank you very much, panel, Nico, Paul, and Eric. Excellent presentations. Paul, I especially liked your video. Very well done. It was very practical. And I think that addresses the kind of the spirit of this program and the personality of this program. We really want to stress hands-on, and I appreciate what you did there. We're going to move on to our last panel. It's musculoskeletal. It is led by Dr. Stanley Liu from Stanford, and his panelists are Ed Weaver from Seattle and Richard Lewis from Perth. So Stanley, I'll give you the floor and introduce your panelists, and look forward to this next hour. Thank you. Stanley, the team says you're muted, so if you can unmute yourself, that'd be great.
Yeah, got it. Let's see. Okay, thank you very much. Let me share screen. Oh, someone, can you release the share screen to me?
Okay, it should be ready, Stanley.
Awesome, thank you. All right. Okay. Okay, can you guys see the screen? Okay. Yes. Assuming good. Okay, great. All right. So very excited again to join the course this year. And we'll be joined with Dr. Weaver, Dr. Lewis this morning. Dr. Weaver is going to go over genioglossus advancement with us, Dr. Lewis with the transpalatal advancement, and I'll be talking about maxillary expansion. To start, I just wanted to try a brief exercise. I think it's actually going to be a little bit telling because, you know, the addition of musculoskeletal surgery has been a really nice addition to the course in sort of contemporary form. And if you have access to, you know, an iPhone or a phone or a computer, just try to go to this thing here, put in the code, and we'd love to see your responses. You know, when we think about, or what do you think about skeletal surgery for OSA? And this should pop up really, really quickly. And it's kind of, this is kind of the word cloud thing. And then you should be able to see all of our collective responses. So give it a try. Hope it's running well. I haven't seen any responses yet. There you go. Comprehensive. Great. It's just working somewhat. And I think, yeah, so everybody can. Very cool. Maybe folks are having issues logging on, but if you just go to the website here, .menti.com, put in the code, and you got it. Last resort. Goodness gracious. Okay. Important and not sure. This is the best attempt I have to get some kind of interaction via the Zoom portal. But, you know, and I think the way this works is the bigger the word, the more, you know, frequency of the responses. So this is cool. This gives me an idea of what folks are thinking about skeletal interventions for sleep apnea. But I see a lot of, you know, perhaps last resort, see a lot of pre-op dental, you know, not performed by ENT. Good. This is why we're doing this course. 50-50. All right. Basically, very not so committal in the interest of time. This will keep running, and then I'll send out the survey, okay, to you guys when we're done. And we'll see. You know, it might be interesting to kind of think about this again after our panel today. I just have one more here before I turn this over to the presentations. Let's see. How do you, I think I'd have to, let me end this thing. Okay. My apologies. All right, then let's try this one. Let me skip this one. It's still going. All right, I don't know how to stop it. Okay, the next one, really, I was just going to get an idea of, you know, for next year, what are the procedures that we want to see in the cadaver lab? So here you go. Okay, so one more. You can make multiple selections. So for next year, right, what do you want to see in the cadaver lab? Transpalatal advancement, genioglossus advancement, endoscopic maxillary expansion, or MMA. And this is super helpful. And this, again, it gives me one chance to feel very engaged with the audience that we have on board today. And so, and as you know, we will be able to very adequately cover the practical clinical use and indications and how we do the first three procedures, TPA, geniogloss, and dome. And then we'll save the MMA for another day. So good. So thank you. Thank you very much for allowing me to get a sense of our audience, our crowd, get some interaction going. And let me now then turn this over to play the first video. And we'll play the first video by Dr. Ed Weaver on genioglossus advancement. So thank you. And like I said, I'll send you guys the results of this when you're done with the voting. And I'll quit sharing here.
I'm Ed Weaver, and I'm presenting on genioglossus advancement. I have no relevant industry disclosures, but for those who attended the course last year, I must disclose that I did shave my beard. This is me, Filippo Montevecchi, one of the course co-directors, and Stanley Liu, the moderator for this session. For genioglossus advancement, I want to present the concept and goals briefly, and then spend most of the time talking about technique and tips. I'll touch on briefly on outcomes, and then finally discuss adverse effects and how to manage them. The concept of genioglossus advancement relies on the fact that the genioglossus muscle attaches to a specific point on the front of the mandible called the genial tubercle. And by making an osteotomy designed to capture that tubercle and advancing the bony segment with the tubercle, we advance the genioglossus muscle. The approach to this osteotomy is to make a gingivolabial incision and expose the mentum, and then design the osteotomy to capture the tubercle to advance. The actual dimensions of the osteotomy are based on the anatomy and not necessarily as diagrammed here in this sketch. There are important concepts, though, to keep in mind in designing the osteotomy. It's important to leave a minimum of 8 millimeters of inferior rim to prevent pathological fracture. Superiorly, it's important to design the osteotomy to avoid the tooth roots, and the window is based on the tubercle location and the tooth roots and designed in such a way to capture the tubercle while avoiding the tooth roots and maintaining an adequate minimum inferior rim. It's more important to capture the top half of the tubercle where the genioglossus muscle itself is attached than it is to capture the bottom half of the tubercle where the geniohyoid is attached. But ideally, we capture both. An important concept is that the cuts need to be parallel to each other so that the bony segment can be slid in or out. But it's not necessary that they're horizontal as diagrammed here. They, in fact, can be angled such that you avoid tooth roots and capture the tubercle. And as long as they're parallel, you'll be able to slide the bony segment in or out. So here's some images of a genioglossus advancement. Here you can see we've made the incision, exposed the mentum, have made the rectangular osteotomy. We've placed a position screw to help control the bony segment. And first we push it in to obtain hemostasis at the bony cuts. And then we pull it out. And we pull it out gently. And once we pulled it out, so it's the internal cortex is now outside the native outer cortex, we rotate. And you can see there the genioglossus muscle attached. We then remove the screw and the outer cortex and thin down the bone so that we have a low profile. And again, you can see the genioglossus muscle there attached. We then secure that segment with an inferiorly based screw so that it doesn't rotate and fall back in the hole. And then close the wound. And here's what it looks like on profile. Here's what the incision looks like after it's healed. It's hard to even notice the person had the surgery. Now, in terms of steps of preparation or pre-op evaluation, it's important to evaluate the teeth themselves. If the person has unstable teeth or bad gingival disease, they might be a poor candidate for this because they might have an increased risk of losing their mandibular incisors. If they have bruxism, then they'll have flattening of the teeth such that the height of the crown is shortened and must be taken into account when measuring the tooth roots relative to the crowns. If they have tori mandibularis that are large, they'll get in the way of the osteotomy, and I prefer to remove those at a separate time before doing genioglossus advancement. We get preoperative imaging, either Panorex X-ray or a CT scan. And key there is to assess for mandibular health, look for the mandibular canal with the nerve in it, and look at the mandibular incisor crowns to root dimensions so you can anticipate the location of the tooth roots. Additional tips for performing genioglossus advancement. I get a preoperative CT scan so I can really measure the root location exactly, measure the tubercle location exactly, know exactly where the nerve is to make sure I avoid that. it shouldn't really be anywhere in the field, but in rare cases it can be. And so I can really be prepared ahead of time. During the surgery, I palpate the geniotubercle with my left hand while I do the surgery with my right hand. The head is in neutral position, and again, we make sure that there are parallel osteotomy cuts, even if they're angled. We preserve greater than 8 millimeters of inferior mandibular rim, and the trick is to use a very thin sagittal saw blade so that you have very little bone loss when making the osteotomies. Also key during this surgery is maintaining hemostasis, because the osteotomies will bleed from the medullary space of the bone. So we induce controlled hypotension with our anesthesiologist, ideally with a mean arterial pressure less than 75 millimeters of pressure. We apply ice cold irrigation to the wound, and we apply thrombin gel foam and pressure until we have adequate hemostasis. And that's with the bony segment pushed in. And then once we have hemostasis, we pull the bony segment out. Now, I'd mentioned that the osteotomy does not necessarily have to be a rectangle as designed in that diagram. In fact, here are examples of various different shapes of osteotomy. This is a rectangle turned 90 degrees. You can see the genioglossus muscle there. Here's one turned 45 degrees or less. I usually turn it only 30 or 45 degrees because the more you turn it, the more a twist you put on the muscle, which can harm the muscle. Here's an example of a trapezoid-shaped osteotomy, and that was to avoid the canine mandibular tooth roots, which curled medially toward the osteotomy. Here's a house-shaped osteotomy, again, to avoid the tooth roots. In terms of outcomes, this was a meta-analysis of isolated genioglossus advancement based on 5 studies. It was only a total of 24 patients, so they're very small case series. But what it showed was that the apnea-hypopnea index reduced from well into the severe range into the low moderate range with this procedure alone in these cases. And Epworth Sleepiness Scale also improved substantially. More commonly, the genioglossus advancement is combined with hyoid suspension, which is described in a whole separate section of the course. But when those two are combined, the results are further enhanced, such that in this meta-analysis, 4 other studies showing that the apnea-hypopnea index went from 35 down to 15, so in the severe range down to the borderline mild moderate range. And again, lowest saturation improved. In terms of adverse effects, there's a host of potential adverse effects, and I want to go through these and help describe how to manage them. First is tongue swelling. That's very common, but it's temporary. And there we manage it typically with just ice and steroid. Floor mouth hematoma is also fairly common, especially if there's elevated blood pressure during the case or at emergence from anesthesia. So managing blood pressure is key. Also applying ice to the chin and ice chips to the mouth can help reduce this floor mouth hematoma, and raising the head of bed can also help. It's very common to get numb mandibular incisors after the surgery. Almost always it occurs temporarily, and about 50% of the patients it persists permanently. It has no functional adverse effects, so here we just observe. A tooth root injury is rare if you've planned your surgery accordingly, but if it does occur, we just observe, because typically the tooth will still survive even if the bottom 10% of the tooth root is excised. One of the risks during the surgery is that after the osteotomies are made, that it turns out you have missed the geniotubercle and haven't captured the genioglossus muscle. If that were the case, you'd simply replace the bone in its native position, put a microplate on and let it heal in, and come back another day with a redesigned osteotomy. If there's dehiscence of the incision, and even if there's exposed bone, typically just observe and that'll granulate in and heal in just fine. If there's infection and abscess formation, however, then it will require antibiotics and incision and drainage. And lastly, if there's an adverse cosmetic effect, it may require revision. This is really rare because the soft tissues overlying the mentum are thick and really camouflage that thin bit of bony segment that sticks out. But I have had one case where a patient could feel it and didn't like that. And so I went back in months later and really thinned it down, and the muscle was already scarred into place. And I want to talk lastly about, in more detail, about floor of mouth hematoma, because that's the major acute adverse effect that can be concerning. So here's what it can look like. It looks like ecchymosis and swelling in the floor of mouth. And when severe, it can really cause the tongue to rise up and add to additional edema to the tongue. And in this case, you even see some ecchymosis of the chin. This occurred because this person had a dramatic jump in their blood pressure at emergence from anesthesia when they're bucking and agitated. So it's important to avoid those things. In this case, this is an airway risk. And so that's why it's a particular concern. So how do we manage and how do we prevent and manage hematoma? And key is the blood pressure control. So intraoperatively, keep a mean arterial pressure less than 75 millimeters of mercury really helps. During anesthesia emergence, it's important that it's gentle. And so a careful, detailed conversation with the anesthesiologist ahead of time. And even doing a deep extubation can help with this to avoid that blood pressure surge that can really cause increased hematoma formation. And then postoperatively, keeping the mean arterial pressures less than 85 millimeters of mercury will help. Ice applied to the chin with a jaw bra strap and ice to the floor of the mouth with ice chips also help immensely. Head to bed elevation is also key, and that helps with the edema as well as hematoma formation. And then we also give steroid to everybody after this surgery, really for the edema, which would compound hematoma formation. And lastly, there's this complication, tongue protrusion. Patients ask, is my tongue going to stick out of my mouth after this? And the answer is no, that does not happen. So thank you for your attention during this gene losses advancement presentation, and we'll take questions at the end of the session.
Hi, this is Dr. Richard Lewis from Western Australia, and I'm going to be talking on transpalatal advancement. Thanks for listening to my talk. I'm an investigator for the Nyxoah bilateral hypoglossal nerve stimulator. Why would one want to perform hard palate surgery? Well, the commonest site of obstruction in sleep apnea is the retropalatal part of the oropharynx. However, UP3 alone will be unsuccessful treatment in many patients, potentially 50%. Manometric studies have suggested that 75% of UP3 failures continue to obstruct at the level of the palate, and 50% or so do on endoscopic studies of post-UP3 failures. This can lead to, or this has led to searches for better ways to stabilize the retropalatal airway. And how could we achieve that? Well, there are really 3 methods to achieve that, and 4 if you want to include hypoglossal nerve stimulation, which can sometimes achieve that. The first is maxillomandibular advancement, followed by maxillary expansion and transpalatal advancement. So maxillomandibular advancement can be a very effective tool to stabilize not only the retropalatal airway, but also the retrolingual part of the oropharynx. But this technique will be covered in another talk in this session. The problem is that in many adults, this sort of surgery is declined due to a number of factors, including the extent of the surgery, changes in appearance, and financial imperatives. Maxillary expansion is commonly used in children and adolescents to correct a crossbite or a narrow maxilla. In the adult, however, after fusion of the palatine symphysis, osteotomies have been required to enable expansion to work. This, of course, does result in changes in bite, which usually requires orthodontic therapy to correct that. But recently, there have been some success with newer techniques of maxillary expansion, and that will also be discussed by another speaker in this session. This was a paper from Peter Sistuli's group in Sydney, which demonstrated for the first time a significant reduction in sleep apnea severity in 10 patients with sleep apnea and maxillary narrowing. In 7 of these patients, the apnea-hypopnea index returned to normal following maxillary expansion. The third method to increase the retropalatal airway dimension is the transpalatal palatal advancement. The principle of this operation is to shorten the hard palate, thereby pulling the soft palate forward and increasing the size of the airway. The operation was conceived of and first performed by Tucker Woodson and published in Laryngoscope in 1993. In its original form, he used a Gothic arch incision with a flap of mucosa raised off the palate. The soft palate was separated from the posterior border of the hard palate, and approximately 1 centimetre of bone was removed. The soft palate was then advanced and reattached to the hard palate with a couple of drill holes in the remaining hard palate and sutures looped through them and then through the palatine aponeurosis. In his original series of 11 patients, 6 had transpalatal advancement alone, and they're shown in the left-sided panel. 4 of these were successes according to the Scher criteria, and 2 others had significant reductions in their sleep apnea, as you can see. However, according to the Scher criteria, they did not pass. For all 6 of the transpalatal advancement alone cases, the RDI decreased from 52 to 12. For the entire group, with the rest of the patients having, in addition, some tongue reduction surgery, the RDI decreased from 73 to 25. Lateral cephalograms taken before and after transpalatal advancement show significant increases in the cross-sectional area of the retropalatal airway in the sagittal plane, with a 2.5 time increase in the cross-sectional area of this airway. The second paper on the technique, published 4 years later, looked at the changes in the airway area and collapsibility in 6 patients, first undergoing UP3 and then transpalatal advancement at the same operation. They were all paralysed and had the airway isolated to demonstrate pressure and area curves. The small series shows that the cross-sectional area of the airway was significantly increased by transpalatal advancement, and the critical closing pressure of the airway was much more negative with transpalatal advancement compared to UP3, which indicates a much more stable airway. After getting a few fistulae through the palate with the Gothic arch incision, I changed to a propeller-shaped incision, which offered potentially better vascularity of the palatal flaps. As you know, the greater palatine arteries are the major blood supply of the hard palate mucosa. And as you can see on the diagram on the left of the screen, the greater palatine arteries come out of the greater palatine foramina each side. So the propeller incision, which is shown in the diagram on the right, is a midline incision respecting the vascularity of the palatine mucosa, which then flares out either side posterior to the greater palatine foramina. The technique was discussed in a series of 60 of my patients by my fellow and myself, which we published in 2009. The technique of this operation is that the incision is made down onto the palatine bone, and then the 2 oblique limbs of the incision go out over onto the palatine aponeurosis. The flaps are raised bilaterally out to the greater palatine foramina, and I put a Freer's elevator into the greater palatine foramina each side to keep the flaps elevated and held out laterally. And I'll show this in a short video clip. Then 1 centimetre of bone is removed, preserving a small bar of bone posteriorly, still attached to the palatine aponeurosis. The aponeurosis is divided medial to the hamulus bilaterally, and this frees up the osteotomy and the soft palate. And the palate can then be advanced forward to close the osteotomy and then fixed in position with 4 0-vicryl sutures passed through the fixation holes. This is a short video showing some of the steps. This patient had severe sleep apnea and had previously had tonsillectomy. You can see little incisions marked for a modified UP3, and you can see the markings for the transpalatal advancement, together with an arched incision right around the hard palate. Monopolar cautery is used to divide the soft palate right down to the palatine aponeurosis, which has a silvery appearance and is very easy to see. And the cautery is also used to divide the mucosa in the midline down to the bone. A Freer's elevator is then used to elevate the mucosa off the hard palate. This can be very densely adherent in some people and quite hard to elevate, but with careful attention and work, it elevates up cleanly in most cases. It's elevated bilaterally right out to and beyond the greater palatine foramina. The greater palatine arteries are very easy to see, and you can also see the junction between the palatine process of the hard palate and the maxillary process, the maxillary bone. You can see the Freer's elevator there being inserted into the greater palatine foramen on our right and the patient's left. And now another Freer's elevator is being inserted into the greater palatine foramen on the other side. They are secured against the Boyle-Davis gag, and that enables the flaps to be kept out laterally. I then remove the bone with a drill. I drill a couple of little holes down to the nasal mucosa and then use a kerosene punch to remove the bone. The next step is to divide the palatine aponeurosis medial to the hamulus of the pterygoid. Once the aponeurosis has been divided, I spread the tissue deep to the aponeurosis with some scissors to get mobility of the soft palate in preparation for the advancement. I try to preserve the nasal mucosa where I remove the bone by carefully drilling onto it and then using a kerosene punch. Then 2 drill holes are made to accommodate the sutures for the advancement. I have preserved a fairly thick bar of bone in this case, but it can be made a lot thinner than that. And as you can see, I can't quite free that bar of bone yet. So that is still attached to the voma. And I then get some scissors underneath the bar of bone. They usually need to be quite strong scissors, such as Mayo scissors, and cut through the remaining bone of the voma and any mucosa there to completely free that bar of bone. This is a very important step, and unless that bar of bone is totally freed up from the mucosa on the nasal surface and the voma, it won't advance. Now you can see it's free and it advances very, very easily to close the osteotomy. You can also see that the nasal floor mucosa is largely preserved intact, and this reduces the likelihood of a fistula. 2 ovicral sutures are placed through each hole with a 5/8 needle and around the bar of bone and tied down, and this closes the osteotomy. The next step is to close the mucosal flaps. When you fold them down, you'll note that there's a large amount of overlap now, and this is proportional to the amount of advancement. Clearly that can't be closed with that degree of overlap. So you need to very judiciously trim the mucosal flaps. You mainly trim the glandular tissue that is in that thick flap, preserving most of the mucosa. And I prefer to bunch up the mucosa a little bit rather than trim it and make it too tight. Once the mucosal flaps have been trimmed, the incisions are closed with, once again, a 2 ovicral suture, and I use a 5/8 needle, which makes it easier to pass the sutures. And there's the incisions closed with at least a centimetre of advancement of the soft palate. the 60 patients in the series of transpalatal advancements had an average age of 45, a preoperative RDI of 37, and an average BMI of 29.45. The oxygen desaturation data are presented in this scattergram. This shows the lowest oxygen saturation with the preoperative data in the recorded by the red dots, and the blue dots the post-operative lowest oxygen saturation, and this reached statistical significance. The improvement in the RDI is shown here, and this was also statistically significant. There was no significant change in BMI compared to comparing the pre and post-operative numbers. There was a significant improvement in oxygen saturation and RDI. Overall, for the entire group, 63% of patients met the share criteria for success, with 71% of patients improving and 35% of patients considered cured. When the patients who had the propeller incision were further analysed, the success rate was higher, as were the improvement and cure rates. The propeller incision patients did not have any significant improvement in BMI compared to the overall cohort. And I think that the better results achieved in those patients was probably due to greater bone removal achieved with the propeller incision, which enables me to remove bone more laterally than the Gothic arch incision, and also more thorough freeing up of the palatine aponeurosis and better mobility of the soft palate. Transpalatal advancement can come with some complications, including oronasal fistulae. I had several fistulae early in the experience with transpalatal advancement. However, I haven't had any of these for several years. And I think that the reasons for that include improved vascularity of the mucosal flaps with the propeller incision, also changes in technique, specifically much better release of the palatine aponeurosis and advancement of the flap without any tension, which is critically important to prevent wound dehiscence. Palatal incompetence has not been described long-term after transpalatal advancement. However, as is the case with a modified UP3, it's common to see it in the first day or two after surgery. Transient middle ear effusions can occur. They are uncommon and they resolve spontaneously. There is some judgment, I think, in deciding when to do a transpalatal advancement, but I've tried to break it down into a few scenarios. The first would be a patient with moderate to severe sleep apnea who has a vertical soft palate and AP narrowing of the retropalatal airway. They would also need to have either absent tonsils or small tonsils and small lingual tonsils. The palatal phenotypes have been beautifully described by Tucker Woodson, who kindly shared this slide. The transpalatal advancement is appropriate for the vertical palate phenotype shown on the right, and in some cases of intermediate palate phenotypes. The second scenario could be this, where a patient has had a previous UP3 but still has residual significant sleep apnea. Even if they have an oblique palate phenotype, as long as there are no other obvious signs of narrowing, a transpalatal advancement may be appropriate with or without revision of the UP3, depending on the appearances of the palate. To conclude, the transpalatal advancement is a procedure which is usually combined with the modified UP3 and can provide a greater increase in the retropalatal airway volume and a greater decrease in the critical closing pressure of the pharynx than a UP3 alone. As an isolated procedure, it is not as painful as a UP3, and long-term complications are very uncommon. Thank you very much for listening.
Thank you, Dr. Lewis and Dr. Weaver. What we'll do is we have about 35 minutes, just about. I'll finish my portion very quickly in under 15 minutes, and then we have time for Q&A. And also, I know that Dr. Weaver has also very kindly prepared a case for us. So let me, no further ado, let's go to the next topic. Okay, so we're talking about DOME, distraction osteogenesis maxillary expansion. And yes, I'm introducing this as a rhinognathic procedure. That's right. So it's a nasal maxillary procedure. I have no relevant financial disclosures. So this is interesting. The late Dr. Bill Dement started this course at Stanford called Sleep and Dreams, and it's a very popular course for the undergrads. And I took it as an undergrad, and I've gone back to teach. And I just, just for fun. I mean, so remember, these are 18 to 22-year-old college students, and I have just not a whole lot of, may not even have interest in surgery or anatomy in general. But I would show up something, I would show this, and every year I would ask them, like, and I mean, if you had a choice, would you want to have the maxilla, that looks like A or B? And I have to tell you, the answer is very unanimous. It's always B. Now, they give funny reasons as to why it might be, but anyway, it always tends to be that. So then I kind of feel like, well, there's not a whole lot more for me to really talk about. So why does that maxillary morphology mean so much, in my opinion, when it comes to the treatment of sleep disorder breathing? Well, a couple things. You want to establish breathing through the nose. I mean, it's not just during the day, but during sleep. When you breathe through the nose, of course, you create negative pressure. These are CFD generated images, and the negative pressure collapses the soft tissue. And then, of course, the soft tissue is then supported by the maxilla and also by the mandible. So this entire complex works together. Ideally, if you had a real deficiency in any one aspect of this, you would want to address it. Love the responses from the mentee just now, really, and I think this is a really fair, feedback when it comes to skeletal surgery. It is important, but we're not sure about it. Okay, and I really love this one, risolutiva. I think I looked it up. It's Italian apparently. This is the algorithm that I use in clinic. I've been using it for a couple of years. A couple good things about it. You can see that it is on the continuum, because ultimately whatever we recommend for the patients decide what they want to do when it comes to the procedures. The other thing is just that, when you look at this, where does skeletal surgery come in play? Well, we talked about transpalatal advancement. We talked about genioglossus advancement. I'm not going to talk about the MMA today, but these are all skeletal surgery. But this is probably less commonly thought of in the sense that DOME, or maxillary expansion, is a very, very important nasal intervention. And it really comes down to the difference between this phenotypes. If you're going to remember who you will want to consider doing a maxillary expansion on, you're thinking about this patient, right? You're thinking about this patient where the tongue is not going to fit in that upper jaw, has this narrow arched form versus something like this, a nice dome-shaped maxilla where you have nice wide nasal floor and room for the tongue even during sleep. Okay, so why else is this important? Well, it makes everything you do better. When you do your UPPs, at some point you're expanding the soft palatal muscles. And if you're going to do that, you probably prefer to do it in a wider maxilla than in a narrow maxilla, because you are ultimately limited by the skeletal landmarks. Even when you look at tongue base, you look at a tongue base procedure, and it looks good from this view. In term, from a sagittal standpoint, you've reduced lingual tonsils and fat in the tongue base. But then if you look at it from a transverse perspective, it's still not going to fit, right? Because you're not really going to go at the lateral, areas of the soft tissue tongue. When it comes to, hypoglossal nerve stimulation, this is what the tongue does. It curls, the lateral pharyngeal wall opens, the tongue base pulls forward. Ideally, if you're going to do this, you would want the tongue to fit in something like this versus that, because this invariably causes the patient to mouth breathe. And now you're going to have a whale of a time titrating the patient post-op to find an optimal voltage where it's not too high and they can fall asleep and etc. And even for the MMA, I will not perform an MMA surgery on a patient with a narrow maxilla for a lot of reasons. When we look at historically, when we look at the MMA, it carries it has a unacceptably high rate of nasal obstruction post-op. And we wrote out an entire protocol about how we could prevent it, but you're not going to prevent it in a patient with a narrow maxilla that you advance. And so in expanding the maxilla, you have a lot more freedom in how you do the AP movement and optimize both breathing and facial balance. So is this even a new concept? Absolutely not. Absolutely not. Journal of Laryngology, Otology, 1975. To my understanding, Dr. Gray was an otolaryngologist from Perth. And while he was doing maxillary expansions for these indications, for pediatric patients with poor nasal airway, septal deformity, et cetera, et cetera. And by the way, if you read this paper, it's really interesting because the symptoms that's described of these kids sounds awfully much like pediatric OSA. So a very, very nice study that we did, or Ryan Williams, one of my former fellows, did when he was with me, was to look at patients who's had septoplasty turbinate reduction, and based on their nose or snot scale, the non-responders, if you will, to classic intranasal surgery. And basically, long story short, they tend to have this very narrow maxilla. But of course, you know that because opposite to this is around the internal nasal valve, and this is now a long, narrow tube that the patient's going to have to breathe through. Now, orthodontists have been doing this for kids for a long, long time. Now, they do it so that, the teeth fit, and that's cool. And this is a really easy process. They could do this thing you just saw here in 3 weeks, okay? Very little pain. They expand the maxilla, and then the teeth walks back, and that's great. What does this do actually for kids with sleep disordered breathing? Well, at least we know that it does open up the internal nasal valve angle. We talk a lot about the internal nasal valve, and we often forget that it's not the hypotenuse. My math sucks, but the floor, right? The floor is part of this, and the floor can be expanded if there's not much else that you can do for the internal nasal valve. Dentists have been doing this for a long, long time. Dentists, oral surgeons have been doing expansions for crossbites, meaning when the upper jaw is narrow, want to fit in the lower jaw. The problem with that is when you do so, the teeth go where they want to go, but you still have very limited space for your tongue, and it doesn't do a whole lot for nasal breathing, and it relapses really quickly. And so in the perfect world, what you want is you want to expand below the nasal floor, but you don't want to mess with the teeth a whole lot in an older patient. And so two advances in the last 5 to 6 years really made this possible. And that is that modern day orthodontia, the ability to use these little mini screws, that doesn't integrate with the bone, but doesn't push against the teeth, all right, but it pushes against the bone. And also understanding that we need to release the LaFour, the maxilla at the LaFour level to have nice symmetric expansion. And the end goal is to open up the region around the internal nasal valve maximally. So, and the reason why you don't want to do it any other way is ultimately to decrease uncontrolled pressure going up to other parts of the maxillary skeleton. Anyway, we did our first series a number of years ago, and we were enthused to find that the patient response, to nasal obstruction greatly decreased after dome, and it was very, very consistent. And the largest series here that we've done with 75 subjects that we've published. Anyway, there you have the results. Now, listen, this is not a standalone procedure, meaning patients do this and they move on to MMA, they move on to hypoglossal, they move on to palate surgery, or some just only get the dome procedure. How does this thing work? Well, I mean, this is just our best guess. We think it opens up the internal nasal valve. We've shown that. We also believe that when we do so, and when we run our CFD analysis, what we end up seeing is greatly decreased nasal airflow through the nose, less negative pressure that collapses the airway. So how do you do this practically? Nowadays, very, very simple. Your orthodontist or dentist or dental labs can actually do an intraoral scan, and you can just scan and you get a nice, basically you can design a little expander. You place this expander, then it's just your Stanford Lefort approach, and you split, and I'll just run the video. And we actually have time for that. So this is, to those of us who lived in a previous era, I mean, this is a very common mid-face degloving, not that much more than, say, an open Caldwell Luck or something. But so you deglove the mid-face, and then you make so I'll just show you the Lefort osteotomy. Oops, my apologies. Okay. So there you go. So you just make that cut. So again, I stress the importance of this cut is, when the upper end of our patients are in their 50s, right? That bone is really dense. So you're not really going to be able to expand this unless you separate it. And you certainly don't want to expand anything above the Lefort 1 level. So it's one osteotomy, you're done. Okay, one osteotomy, you're done. And how do you split? This is using a piezoelectric blade, very, very commonly used. A lot of rhinoplasty surgeons are using this for their cases as well. And you just kind of go into that groove, you make that little groove, and then there's a little bit of osteomidge, okay? A little bit of osteomidge. You want to have 2 osteotomes on the side and 1 in the middle, and that way it separates the bone without a risk of injury to the tooth roots, okay? And so you tap, and you'll see it'll split right there. And then you make a few turns on the expander so that you basically, now the patient walks out with this maxilla reliably expanded. So it's a little key. You teach them how to use it. This is the same as the key that kids use, and that's it. Every turn is 0.25 millimeters, and then you just turn this for the next month or so. Okay. And then in the open procedure, even with fellows, this is something you can do in less than half an hour for sure. Okay, so here's the process. You start after 1 month, you have this massive expansion, and then you close this bite. So then you're saying, well, I don't want to deal with this massive hole, gap between my teeth. There's no way, any of your patients go for it. Well, that's not true, because with Invisalign trays, what they do is they'll just basically put in the fake tooth in the middle, right where the gap is. And as this gap closes, this just kind of goes away. Okay, so the acceptance rate is really pretty high. Where do we go next with this? Remember, I said this is a rhinognathic procedure, meaning if you have patients with septal deviation or problems with the septum per se, especially in the posterior, because the vomer will expand with you, and you may not want that. So probably the best thing you should do is to do your septoplasty, turbinate reduction, and dome at the same time. That way, you also don't have to open this thing up as massively as we did in previous years. So of course, then this is called a mini dome for minimally invasive nasal endoscopic approach. I think I should credit Dr. Weaver because I like his nasal valve suspension approach. And really, this is very, very similar in terms of the approach. So you make an incision and a lateral piriform rim. You find all the same landmarks, and then you cut this basically with a sonopet blade. So next year in the cadaver lab, I'll be happy to show you this. It works very, very nicely. This is now an outpatient procedure, no more than the sinus really procedure recovery, and a lot less paresthesia. So with the mid-face degloving, the facial numbness lasts, and it can last for quite some time. With mini dome, at least the vast majority, well under 1 month, if not much shorter. Okay, so what I hope you get out of this today, good, almost there, is that when you're in clinic and you see these patients, yes, nasal obstruction, tonsillar hypertrophy, redundant soft palate, big tongue. Just don't forget to look at the roof, because by expanding that, then your UPPP, your tongue-based procedures, your genioglosses, your MMAs, it's just going to work better. It really is going to work better. Whereas when you see something like this, where it looks pretty decent, and chances are the nose and the palate looks pretty decent as well. Another concept, when you have a patient like this is a patient where really couldn't find any other anatomic issues per se for her symptoms, but if you look at the width of the tongue to the size of the upper jaw, so I do this. I scope the patients and I just ask them, like, do you think the tongue fits in there? And most of them will say that it wouldn't. So the tongue only has 3 places to go, right? It goes back into the airway, or it tries to go up there, in which case this doesn't work, or the tongue sticks out of the mouth. So anyway, this patient, unique in the sense that we just did dome for her, but what I want to share with you here is, remember that this is the entire airway. So when you see an epiglottis collapse with nothing else collapsing around, it may not be an isolated epiglottis problem. It may be an airflow problem, and you can address that, with nasal breathing or treatment of nasal obstruction. So when you expand the protocol, when you think about nasal obstruction, just want to point out that if the patient has this phenotype, just remember the dome in this entire mix of procedures that we can do for nasal obstruction. Finally, when we see this, all right, so this is, I'm going to tell you, this is a 9-year-old child. See evidence, ways we can help her with nasal breathing, maybe with tonsils, maybe lingual tonsils. But what's the impact of all of this really at the end is that when you have nasal obstruction and when you have it in a very asymmetric format, this is the beginning of an asymmetric facial growth, and this is the beginning of a lot of grief for the patient's facial and airway development in the long run. So in my opinion, nasal maxillary narrow maxilla can be recognized very early on, and almost always is a nasal problem. A lot of this work, honestly, these fellows have really pushed me along the years to do this, and a lot of them have incorporated this into their practice. Anyway, reach out to me however you like. And thank you very much. And now we'll do the Q&A or Dr. Weaver's case. Thank you.
Stanley, I propose we just do Q&A. I think we have about 7 minutes left. The upshot of the case was just showing how skeletal surgery can complement soft tissue surgery. So there's a case where the soft tissue surgery resulted in a good anatomic result, but there was still collapse in sleep, and the skeletal surgery stabilized it. But I think there's been quite a few questions on the chat that I think we've been trying to keep up with, but I propose we spend the last 6 minutes or so just doing Q&A or enjoying Richard's background.
Is that a real background or a virtual background? I can't tell.
You're muted, Richard.
Sorry, I'm really in Japan.
Oh,
no, it's just a picture.
So Stanley, this is Scott. Thank you all for your presentations. Stanley, while you were giving your presentation, as Ed said, there are many questions that you might want to roll through and just see what you could address in the next 5 minutes or so.
Yeah, happy to. I'll read through this real quickly. Let's see. When do you recommend the dome versus the widening of the piriform aperture? And I think the widening of the piriform aperture, especially for sleep apnea, is probably credited to Dr. Weaver as well. So when do you do it? Again, we're talking about sleep disorder breathing. So if you have a narrow high arch palate and the tongue has no room to be, you need to open up the maxilla. So I would say, if it's really a daytime breathing problem and the patient doesn't really have a tongue space issue, I think, your piriform aperture opening with intranasal surgery works great, but that's not going to address the lack of tongue space issue. So I would say that's where I would make that difference. I don't know if Dr. Weaver, if you don't mind adding to that question.
Well, I don't do the dome type procedures, but I have a pretty low threshold to working on the piriform aperture just because it's easy access and very low morbidity. The measurement of the piriform aperture is normally 21 to 22 millimeters, and it's pretty tight standard deviation around that, meaning it's pretty consistent.
Mm-hmm.
And so I just measure it. And if it's narrow, I'll just I'll either trim the bone back a little bit or drill it back a little bit.
Awesome. How do you measure the width of the maxillary roof and the normal dimensions? There's no such thing as a normal dimension. You know, one thing about sleep surgery we have to remember, especially when it comes to skeletal procedures, is that this is functional in nature. So we used to, live in an age when, like, the MMA has to be big and bigger is better. Well, bigger is not better. In fact, in a lot of ways, once you put the jaws in the right place and the patient's doing well, you're done. So bigger is not better, and neither is maxillary expansion. You do it when you need it. So in a staged approach, you've done your septo, you've done TURPs, you've done everything else. And you clearly recognize a narrow high arch palate and the patient still needs help. Well, you expand them. It's just that you may not have to expand them so much. Remember, you have an expander in your hands. If you expand them for, we've done this in some cases when I taught in Hong Kong, you expand them for 4 to 6 millimeters and they feel great, then you're done. So I think, again, it's one of those things where you have to let the symptoms, or those are your outcomes, dictate how much you do anatomically. How much can you open up? They're worried about like the bite. Well, the bite will always fit because you see, you're not going to overextend. Again, your lower teeth are always inclined into the mouth when the upper jaw is really narrow, right? So by uprighting the molars, you always can get at least a centimeter up front. So that's not an issue. Remember, we're doing these in people in normal, seemingly normal bites. You do not want to use your teeth as a guide to be doing this. You're doing this because the upper jaw morphology is very narrow and high arched. The Vivo system, DNA system, here's the thing. The airway is attached to jaw bones and not teeth. So anything that expands the teeth may be effective. We should look at more of the data. But in my opinion, because the upper airway muscles are attached to the bone, we should expand the bone and not the teeth. How do I decide between the dome and the SARPI? Well, the SARPI was a very aggressive procedure. And the only reason why it was aggressive is because we didn't have the mini implant assisted expander devices. And that means you are cutting a full forward, you're breaking the lateral nasal wall, you're breaking the pterygoid plates, and now you're going to have this wobbly thing with a fairly just wobbly expansion process. Especially if you're an older patient, I wouldn't recommend it. With the dome, as I've shown you, it's 2 LaForte cuts and a split, and that's it. So not too bad. No, not too bad. I've never done any kind of Dallaire analysis, et cetera analysis. In 7 years of my MMA experience, I've never measured one lateral ceph. We're treating the airway. We're treating the soft tissue. So skeletal measurements for skeletal tissue, that's one thing, but we need to develop things that give us guides to the soft tissue. But again, MMA procedures are not orthodontic surgery. Orthodontists are afraid of Brody malocclusion. Yeah, exactly. So you expand as much as you're allowed to. Permission to send video of the mini dome. You got to come to the course next year. Do I have oral nasal fistula? Those little screws will not create oral nasal fistula, so that's okay.
All right, Stanley.
Yeah.
I'm going to jump in. I think your questions could go on for a long time. It was a really interesting subject. Thank you very much, Ed and Richard as well. Claudio, we're going to bring you on now for closing remarks. Go ahead.
It will be very easy because it was a great day. I couldn't imagine that was in this way, but it's much better than I expected for my side. It was a great webinar. It was a great talk from all the board, all the teachers. And I think that the next year will be much better, but today I enjoyed a lot. So thanks to all of them. because they gave us the most advanced things, most advanced devices, most advanced techniques. A special thanks to all the attendees. I suppose more than 270 is correct, Scott?
That's right. We were above 270. Yes.
Is more than great. And a special mention to all your Nicholson people, because Nicholson people is great even from far, even from the website. So thanks for your organization, and all of you are invited for tomorrow, of course.
Yes, we'll be back again tomorrow at the same time. I do want to thank the Nicholson Center staff for putting on an excellent webinar today. I want to thank our sponsors again, our gold sponsor, Airlift by Sleep Source Alliance, also our silver sponsors, Inspire, Stryker, Philips, Olympus, and Nixoa, and the Florida Society of Otolaryngology Head and Neck Surgery also for sponsoring this program. Tomorrow we have another 4 hours of panel presentations. We look forward to seeing everyone else again. We've already had 2 people register for next year's meeting. Remember, this will be an in-person meeting, and these procedures that you saw the faculty perform on video today, you will be able to practice those on cadavers. So if you're interested, we will only have 30 spots for dissection. We'll take as many as we can for the lecture component, but only 30 spots for dissection. If you're interested, please sign up early. Everyone have a good day, stay safe, and we'll see you tomorrow. Thank you.
Ciao.
Thank you.
Ciao.